Someone please start countdown.
It is already.
Should we start, Dr. Farooq?
Yes, yes. Come on. 3, 2, 1. Coordinators,
Good evening,
please take on.
Good evening, everyone. Today is the day of the certificate course on endometriosis, and I welcome our ICOG President Dr. Parul, the Vice Chairperson Dr. Elect Chairperson, in fact, Dr. Parag, Vice Chairperson Dr. Sheila, Series Convener, and Dr. Sarita Balerao as Secretary. And I would request Series Convener to please start the program. Welcome our guests and start the program. Hello, please, Series Convener today.
Sheila, start.
Sheila,
Yes.
Dr. Sheila, please.
So good afternoon, everybody. Yes. Good afternoon, everybody. And on behalf of ICOG, our chairperson, our president, chairperson-elect, as well as secretary, I welcome you all for this second day certification course on endometriosis. And very happy to see that all of you have so much of interest and all of you are attending in such large numbers. And I'm sure that definitely this program will be very, very helpful. As all of us, we know that in our practice today, we are experiencing that there is a rise in the endometriosis in a reproductive age group, and we also see the younger age group. So all these, the first day, all the basics are covered, and today again we are going to learn about the fertility with endometriosis as well as adenomyosis. And I'm sure that all the speakers will definitely will be doing justice to the topic today. And now, can I take the opportunity to call our the guest of honors today? And yes, our president, Dr. Jaideep Tank, and Dr. Madhuri Patel are always very supportive. We had Dr. Madhuri Patel with us. So now I would like to invite Dr. Prakash Trivedi, who is our guest of honor today, to give his and to address the gathering. So can I have his CV? Yeah, Dr. Prakash Trivedi. I think nobody in the crowd everybody will acknowledge that he is a gynecological endoscopist as well as a urogynecologist and ART consultant. And he's a director of the Dr. Trivedi's Total Women's Health Hospital, also the Akar IVF and ICSI Center. Okay. He's a pioneer of 3-day 4K laparoscopic, hysteroscopic, as well as urogynecologic surgery and IVF ICSI in Asia. And there are many things and awards to his credit. And he has also received a Health Minister's Award for his research on fibroids in infertility and IVF, as well as he has a Best Research Breakthrough Award for in back that is contained morcellation of fibroid, because we know that there was so much of controversy going on regarding the laparoscopic myomectomy, and I think all of us, we heard that time clearing our doubts. He has performed more than 50,000 gynec minimally access surgery for removal of uterine and pelvic pathologies. He's introduced a 3D 4C ICG Rubina camera in India for laparoscopic surgery for early endometrial and cervical cancer optimally. And also he has published many papers, as well as he has 11 books to his credit. And he is helpful in Maharashtra University recognized post-doctoral training in gynae endoscopy. And I'm sure many who are attending today must be his ex-student and who has learned laparoscopy from him. And also the American Center of Excellence in Minimal Surgery Gynecology for Fibroids and Removal of Uterus and other surgeries as well. And he has many more awards. So we welcome you, Dr. Prakash Trivedi, to address the gathering today. As well as I would also like to introduce Dr. Uday Thanawala, who is the ex-chairperson. And all of us, we remember you are vibrant here. He's a consultant in Navi Mumbai. and he was a chairperson of ICOG between 21 and 22, and vice president of Foxy in 2015, treasurer of PCOS Society of India, and he also served as medical disorders pregnancy chairperson committee in 2006 to 8. Founder, secretary, and past president of Navi Mumbai Obs and Gynae Society, and he was a joint secretary of Foxy in 2005. And he has received a gold medal in FCPS exam, Sir G.M. Masani Prize for Best Research Paper, and many more awards like Dr. D.K. Datta Award for Best Journal Publication, and many more awards to his credit. So I welcome both our guests today to address the gathering.
Thank you, Sheila. I don't know. I don't see Prakash right away. So is Prakash joining?
Yes, Dr. Uday. Yeah, please.
No, but on the email also to register. So we might as well do it.
Yeah, Dr. Uday, please go ahead.
Okay, good. So it's so nice to be here in this ICOG certificate course webinar, something which we had started long back, and webinars are the way to go, is what I think we are realizing, and again and again coming forward. Like there were about 450 some delegates who benefited yesterday and are going to benefit in the next 2 days. And Asha is of course doing some wonderful work in endometriosis, and she has designed this so well. And today's it's topic wise on how the endometriosis affects the woman. So today is a time which is very difficult for any practicing obstetrician and gynecologist, to take decisions when a patient has endometriosis and is suffering from infertility, or has adenomyosis and suffering from infertility. So it's difficult to decide what to do next, whether to do a laparoscopy first or whether to treat her medically first, which cases to remove the endometrioma, which one to just hold on and make sure that they conceive either with IVF or whatever. So it's a very interesting session today. I see stalwarts here like Sarita Bhalerao, Dr. P.G. Paul, Anu is there for their lectures. So welcome everybody, and enjoy this webinar and make the full use of it. And thank you, Asha, for calling me here. And great work, Parul and Sarita. Thank you so much.
Yeah.
Hello.
Yes, Dr.
Yeah.
Kiran, you can go ahead.
Thank you, Dr. Uday, for very, very nice words. Now I would request convener of today, Dr. Asha Rao, to take over the mic and conduct the program further for the preamble and the Dr. Asha Rao.
Yeah, madam, you're muted. You're on mute.
Unmute yourself, Asha. Yeah, you're on mute.
I think the organizers know the person may not be able to do sometimes. Let the organizer do that.
Dr. Asha, please unmute yourself.
I think she's
You are
not
not
able
able
to.
to.
Gauri, please do the needful.
Yeah,
technical
she's
team
already co-host है मैम.
किसको co-host किया है?
आशा मैम को already co-host बनाया
But
है.
on and off it goes
Yes.
into mute.
Yeah.
You muted again, Dr. Rao.
I'm not doing it. It's happening.
Now we can
okay.
hear you.
Yeah,
It's okay, ma'am.
Yeah. Good afternoon, dear friends. It has been wonderful having this 3-day Foxy ICOG endometriosis certificate course. And we had a wonderful day yesterday. Thanks to our stalwarts, Dr. Jaideep Tang, Madhuri Patel, Parul Kotidawala, Sarita, Sheila, Parag, for all the wonderful guidance, support, and opportunity that we have been receiving. And yesterday, the program started on time and with blessings from Dr. Madhuri Patel. And then we had the series convener, Dr. Sheila and Dr. Parag, giving the blessings. And we had excellent lectures, crisp and clear, by the speakers, Kalpana on etiopathogenesis of endometriosis, and we had Kuldeep Jain. Of course, he had some technical difficulties talking about the staging of endometriosis, which is very, very important. We had Dr. Sonal Kotdawala speaking on adolescent endometriosis, what is different. And we also had Sonal Panchal with her beautiful presentations. I think she had a lot of material to tell us. And I'm sure we should have her another day and have many more lectures from her on various aspects of endometriosis. Then we had medical management of endometriosis, very easy and wonderful presentation by Dr. Parikshit Tank, and everybody appreciated that. Then we had the powerhouse of endometriosis, Dr. Ramani Devi, talking on pain pathways and pain management. And so somebody is talking. Can we mute them? We also had Damodar Rao talking on surgery for endometriosis, when and how, because so much has changed in the yesteryears. So it's a very, very important topic. And last but not the least, we had our international speaker, Silvia Venusini, talking on antagonists and its usage in gynec practice. It was a beautiful presentation. And we had the pre-test and the post-test on endometriosis. And I think everybody has done wonderfully well. We almost had, I think once I saw 490 registrations, and till the end, almost everybody was there. That was very nice. So we are looking forward to another wonderful day. And all our speakers are ready with their presentations. And let us go in for the academic program. And thank you, ICOG and Foxy team once again.
Madam, Dr. Prakash sir has joined for the address.
Yeah. Now let me welcome our beloved surgeon, Dr. Prakash Trivedi, who has been just introduced. Prakash does not need introduction. He has been a Foxy president and IAG president, ISA president, and he's a stalwart in surgery, teacher of teachers. And we request you to give your blessings, Prakash. We're honored to have you here today. Dr. Prakash, have you joined?
Yes, sir, I joined actually.
I am not able to see him.
No, sir has joined.
Hello?
We have made co-host also.
Okay.
Yeah. Dr. Prakash Trivedi, sir, are you there?
Yes.
yes. कोई मैं उस बोल रही थी एक बार आप ट्राई कीजिए अगर हुआ तो ठीक है नहीं तो फिर हम कर देंगे
I think Nilima sir is not
Yes.
there. Then we can go
Yeah.
ahead.
Yeah. Okay.
Huh?
Yeah.
Dr. Kiran, you can go ahead
Yeah,
then.
he called me to join, but maybe he has not joined yet.
I think better we proceed. No,
Yeah,
it's
yeah,
getting. Yes, I also think so. I also think so.
Dr. Asha, you
Kind.
Give the pre-test now.
proceed.
Yeah.
Give the
Prakash is-
pre-test.
Gauri,
Prakash is
please.
calling me. Hi, Prakash. We
Yeah,
welcome
okay,
you.
okay.
Yes.
Nilima, please post the
Yes.
test link.
Yes, ma'am. please.
Prakash needs to be unmuted, he says. Prakash needs to be unmuted. He's waiting.
We have made co-host, ma'am.
So everybody please go to your chat box and there is a link posted now for the pre-test. So you can please go and see if you are able to open the link. Once you click on the link, a new window will open. We have 240 people with us now, so let's be on time.
There's a message from Prakash that he needs to be unmuted and the video, and he's here since 10 minutes. So Prakash, what name are you under? Because we can't see you here. So can you just type that out?
Yeah.
Can somebody call up Prakash? Asha, just call him up and see. Please sort it out. Even I couldn't find his name.
For the pre-test, 7 minutes, 30 seconds are left. Dr. Trivedi, we cannot see your window. I've checked all the windows now. Admin, can you put a helpline number? There are some people, Dr. Seema Singh and Janki, who are not able to open the link. We will put a helpline phone number for somebody who needs any help. So there is a phone number now on the chat. There is a phone number put in the helpline. Dr. Seema Singh, Dr. Janki, anybody who's not able to join the link, you can call to get some extra guidance on that. But if you go on the chat box, click on the link, a new window will open. So there you can put your details first and start answering the questions. 6 minutes and 28 seconds are left.
Nilima, Dr. Prakash Trivedi is waiting, so we can just locate him once again. He said his video was not seen.
But sir had joined actually. I can see, and we have made co-host also. So sir should unmute.
Can you call him and talk to
No,
him?
sir, Nilima sir has just called and he says he can't do anything. He can't unmute and he can't start his video also. So जरा मैंने उनको बोला फिर से log out करने को, but he can see everybody. He can see Asha. He can see.
Okay, तो उनको फिर से login करना पड़ेगा. Yeah, okay.
Yeah, आप next बोल कर.
उनको जरा बोलो फिर से login करने को.
Yes.
Dr. Anu Bandari, it will open in the new window if you click on the link. Now, 3 minutes and 30 seconds are left.
गौरी, डॉक्टर प्रकाश विधि को भी co-host करो. Sir has rejoined actually.
Now the last 1 minute is left for the pre-test to close. You can check your answers and change them also.
In the meanwhile, I hope we are ready with Dr. Prakash Trivedi to address us. Nilima?
Yes, sir had joined actually, ma'am, and we have made co-host. Yeah, rejoined, sir. Again, rejoined.
Prakash, you're okay? He's still saying unmute, 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 Nilima. I don't know what's happening. Did you? No, it's very. Nilima.
Yeah, sir has to unmute now, sir.
He says he's not able to unmute.
Time's up. You can proceed, Dr. Chen.
Yeah, Gauri, just check Dr. Prakash Trivedi.
Chinky, Randy.
Gauri, Dr. Prakash Trivedi,
Yes,
sir.
ma'am.
Yeah, Dr. Prakash Trivedi,
Just
sir.
a
Yeah,
minute.
just search. Yeah, sir. Sir has joined actually, and we have made co-host. Sir should open.
He says he's not able to show his. I mean, his face is not seen to us. That's what he says.
मैम सर को पोल बनाया है.
వస్తున్నారా?
Yeah, everyone has submitted, looks like. That's very nice. Can we start introducing the chairpersons in the meanwhile?
Yes, please.
So do you think Dr. Prakash Trivedi is not at the moment connected with us?
That depends
So
on
should we start the academic session? Okay, so let's start with the academic session, and it's a right way. We are very much in time.
Only 2 sentences about each chairperson, Kiran.
Yes.
Very brief introduction.
I know we have a very less time, so we'll be very short. So our first chairperson is Dr. Anju Soni, and she is president of Indian Menopause Society this year. She has also been elected ICOG Governing Council member and many others like India CCM, and she has been chairperson of HIV/AIDS. Major achievements are many. She's very fond of writing, Foxy Focus, DCPR, many articles, and has had a lots of awards to her. So welcome, Dr. Anju Soni, for your to chair the session. Then our next chairperson is Dr. Kunji Mohiddin KU, and he is Chief Consultant, Reproductive Medicine, and sorry, this is not. Just a minute, just a minute.
He's a well-known ART
Somehow.
surgeon from Kerala.
Sorry, yeah, no, actually, something has come. Okay, she is from Kerala. His specialization is actually Dr. Prakash Trivedi's messages are coming in between.
Yeah,
He's
because
an IVF gynae endoscopist, and he is chairperson of Kerala chapter. Welcome, Dr. Kunji Mohiddin. The next chairperson is Dr. Nilesh Valkavde, and who doesn't know him, he is his most important introduction is chairperson quiz committee, and he has been conducting fantastic quiz in the Gurukul PG programs. He's clinical head and fertility specialist, Oasis Fertility Pune. He is joint secretary amongst treasurer, have many awards to his credit and many publications. Welcome, Dr. Nilesh.
Hello, Dr. Kiran Pandey.
Yes.
Hello, Sarita ma'am. I think Kiran Pandey lost his connection.
शेयरिंग कर दीजिए जब सर बोले तब आप शेयर
Dr. Kiran, are you proceeding?
Is there a technical problem? Has it stopped the slide presentation?
Dr. Rao, you can continue with Dr.
Nilima?
Gunashila.
No, its slides are not continuing, I think. Yeah, Devika Gunashila is a CEO. She's the managing partner of Gunashila Surgical and Maternity Hospital. She has so many publications to her credit and excellent ART specialist from Bangalore. Next slide, please. I think slides are not moving. We can go to the speaker slide. Hello? Yeah. And can you ask the chairpersons to take over? Is Anju there? Okay, if
Yeah.
the chairpersons are not.
Dr. Asha, we have spoken to Dr. Trivedi. I mean, we are getting to. He will give his address after Dr. Anu's talk.
Dr. Gunashila, Dr. Gunashila is there. She's there.
Devika, where are you? Can she be unmuted?
Yeah, I've unmuted. So I think
you have to kind of introduce Anu Chawla.
Yes, sure. I think we should just get on with it. And then I think it gives me great pleasure to introduce Dr. Anu Chawla, who's the chairperson of the Endometriosis Committee, FOXY, also a specialist in reproductive medicine and minimal invasive surgery, and the director of the London Fertility Clinic. Over to you, madam, for your presentation.
Thank you, Dr.
Can you put the timer, please?
Thank you, the ICOG chairperson and my teacher, Dr. Parul Kottawala, and all the senior faculty present here. I would proceed, and just forgive me for not taking individual names. So I will just start sharing my presentation now.
हेलो हेलो no बीच में कुछ इंट्रोडक्शन स्टॉप हुआ था
Okay, can you see the screen now?
Good evening. Yes, ma'am. Yes, ma'am.
Okay, perfect.
Hello, I'm sorry I got disconnected. Dr. Anu, welcome.
Thank you, Dr. Kiran, Dr. Rao, and everybody present. So just forgive me for not taking individual names. I'll start with my presentation. So in the outset, I would invite all of the attendees today to get connected with the endometriosis committee, and you can write on these email addresses if you want to do work for this committee, which is the endometriosis committee of FOXY. It's a great platform to start your FOXY journey also. I do work both in India as well as in UK. You would remember that most of the times making things visual for patients, we tell them how the physiology works to create a baby. And my talk would focus on the gaps of knowledge. So I'm going to assume here that you all have basic knowledge of endometriosis. I'm not going to talk about the basics. And again, they were covered yesterday as well. So my talk is more focused on filling some of the gaps which you should be aware of when you're reading papers, when you're writing papers, when you're doing your research. So looking at the future is the goal, and filling the gaps. Now, like Dr. William Osler said, somebody who knows endometriosis knows gynecology. It's really the last realm which is still not really understood well. And because of that, we have some invisible gorillas. So what I mean by invisible gorillas is that the whole research and development of the pharma companies or anybody who's exploring the treatment, especially on the medical side for endometriosis, is actually based on the fact that they are attacking the normal mechanisms, which are proliferation, angiogenesis, inflammation, and glycolysis, which are not just because of endometriosis, but they also form the normal pathways. It is just that the ratio is shifted on the higher side. For example, you all know that the TH2 is decreased and the ratio is reversed basically. Now, I would want you all to bring your attention to this paper. If you don't take much from my talk, and if you just take time to read this paper later, it will really enhance your outlook on understanding the endometriosis. It's very different from any other topic in gynecology, we know. So a lot of research, so more than 65% of the whole research of endometriosis actually has only happened in the last 2 decades. So it is the new black. 2 pillars of the contemporary drug treatments are that we know that this ectopic endometrium is estrogen dependent, and that is how we are designing our medications. And also the second pillar of thought is that there is a treatment window offered by the estrogen threshold hypothesis. I'll not go in detail, but you can go and see papers published in 1992 by Barberi for this concept. And a lot of medications that we use are focused on using this pillar of knowledge. So in the last 6 to 7 years, there's a growing evidence indicating that ectopic endometrium fundamentally behaves like wounds. So there is a new term that you will now see being used in the papers, which is called retire, which is a repeated tissue injury and repair. And that is why Dynogest is still not the ideal drug. So the latest drug is Dynogest. You all know that. A lot of people have been promoting, and the good thing is it can be used for years, and a lot of other advantages over the conventional drugs like danazol or the old favorites. So even this suppresses the cellular proliferation and inflammation as if this is not a part of the normal process. We know that it is, and that is why even this is not the ideal drug. Now, coming to the second part of my talk, basically, let's highlight when we treat fertility patients who are the known cases of endometriosis, what are the basic guidelines which are set by ESHRE? So although live birth, so if anybody is doing the papers, publishing studies on doing studies, Now, the most important, the limitation factor of a lot of papers is that clinical pregnancy is the outcome, which is not the ideal outcome when we study endometriosis, because we know that especially in cases of endometriosis, we want to know how many actually went on till the live birth rate. So although live birth rate is a very relevant outcome, because most of the studies are not taking this into account, if you are doing any of your studies and you keep this as the outcome parameter, it is very likely that your paper will be accepted, because there are not many papers focusing on this factor which we want to see. Again, the ESHRE is saying that women seeking pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance the future pregnancy rates. Clinicians should also not prescribe drugs like pentoxifylline or the other anti-inflammatory drugs or letrozole outside the ovulation induction. We all know we should not be giving induction to a lady more than 12 times in life, because all of these understandings are based on the fact that with each stimulation, you are doing something unnatural to the ovary, because the supraphysiological level of estrogen is something that the body is not used to. So we don't know the long-term implications on the sinister nature of any pathology that can develop in the ovaries. In patients without a clear indication for ART, which is assisted reproductive technologies, the value of surgery for ovarian and deep endometriosis and its effect on natural pregnancy rates should be evaluated. The studies should consider the age, the bilaterality of the cyst and the size, previous surgeries, and adenomyosis or other faculties. Now, when we see that, of course, adenomyosis is very commonly present along with endometriosis, the single most thing that you can see in the baseline scan, whether the junctional zone between the endometrium and the myometrium is affected. And if it is affected, then yes, there is enough evidence to say that the implantation rate will be affected in this patient, regardless of having endometriosis for how long or not. So the other thing which we as fertility specialists want to see is EFI, but it is understandably still not very much in the practice and not easy to do also, but if done, has a very good result. And also, we should not forget that there could be other parameters which also should not be forgotten. So all the 4 parameters, the partner sperm, the tubes, the uterine pathologies and the ovarian pathologies should be checked regardless. So if you have found one problem, that doesn't mean there can be not other problems. So just rule out the other ones in the baseline scan. And also, these women should be reassured that so a lot of people do ask questions that endometriosis is an estrogen dependent condition. If we are doing ART, we are increasing estrogen by multifold for some days. So is it going to affect the safety? The answer is no, because it is very short-lived. The whole IVF procedure finishes within few weeks, and hence there is no long-term data to say. So you can clearly answer the patient that no, it does not compromise your safety levels. Now, this is a great image. You can take a screenshot of this. It very clearly shows what are the various factors in which ways pregnancy outcomes are affected in cases of infertility with endometriosis or adenomyosis. And let me tell you, a lot of times you will see both of them are present along with each other. And that is why in the baseline scan, so just giving you an analogy, just a practical tip here. Whenever I see a baseline scan with endometriosis, one thing I never miss to see is junctional zone is affected or not, because immediately I know the implantation will be affected or not. Similarly, in PCOS, regardless of lean or obese, just going off the track, but giving a practical tip, one thing I never miss in the primary scan is to see the stromal abundance. A lot of guidelines have missed this point, but this is a very important point to predict the OHSs. So there are always some tips in the first scan in each type of patient that we must have in our minds that, okay, in this patient, I'm not going to miss this parameter in the first scan, because you will not have the same kind of findings once you have started giving them treatment. So again, this is one of the studies, very important, that yes, there is a strong association with the number of pregnancy losses, and it is a large study done in the whole of the population of Denmark for this, whether the association of pregnancy is there or not. Now, this used to be our old kind of a Bible to follow. So this was an ASRM committee opinion, in which this is a document which we used to follow when we didn't have very clear guidance on the various guidelines. And the summary was that there is an efficient evidence to indicate that the resection prior to IVF improves. And that was the first time when we started thinking, do we really need to do surgeries or not? IVF likely maximizes the cycle fecundity, especially when patients don't have symptoms and they only have the concern for fertility. Higher incidence of preterm delivery, preeclampsia, antepartum bleeding, placental complications, and cesarean section are known in these patients. Again, a very important paper by Paul Perty, one of my favorite new scientists from Paris, and the whole group is very impressive in research and updating our knowledge recently. In the last 4 years, they have come out with great papers. Some of the points that they have highlighted is, in fertility, endometriosis should be identified or excluded on the basis of past history, or confirmation or exclusion, suspicion on the basis of history or physical examination. So index of suspicion, like the old kind of clinicians used to just touch the pulse and tell the problem. So that is the level of clinical index of suspicion that really helps. The moment the patient walks, she starts telling you the story, you know that the endometriosis patient is going to talk in a certain way. So that is going to help avoid the surgery. And if you're beginner and you're not sure, then definitely don't be too afraid from using the tools. So ART first approaches are most often preferred in the 30s, and there's overwhelming data indicate that the results are not altered, whether in case of endometriosis, including endometriomas. Now, this is the research group who is also saying that as long as you have a euploid blastocyst, the outcome is not affected. I would add one point here. If the junctional zone is affected, then even then the outcome can be affected. And this is a new outcome of the PhD student of the Birmingham University, which is going to be published yet in this year. But I know because I am working closely with that group. So I will move forward from this. Some of the important points are these. So safety and efficacy in ART should be clearly established. When should we move to surgery is an individual decision. Don't think it is 5 centimeters, so you have to do the surgery. Yes, your threshold definitely will decrease after 4 centimeters, but there is no clear-cut size. So if there's any question where somebody is asking you the size, the question itself is wrong, because there is no guidance at present which says beyond this size you must operate. It is an individual decision. If the patient has, big size, there are advantages and disadvantages based on the presence of symptoms or not, accessibility to the ovaries when you're doing the oocyte pickup or not, or even just per se based on the size. Depends on the individual practice also and the patient's selection. Let the patient choose after you tell them all the pros and cons. How to improve ART outcomes in presence of adenomyosis? Like I said earlier, we used to do the GnRH agonist multiple times for 3 months and before doing the transfer. That is not promoted now because the evidence does not support such practice. Definitely don't miss the opportunity to propose the fertility preservation whenever you catch them young. What is the impact of endometriosis or donor cycle is also something that we not yet know. So is my time up?
Yes, yes.
Okay, I will just stop very soon and maybe only bring your attention to some slide which I really want to convey. I think I should stop. Thank you very much. You can write to me on the email if you have any questions or the feedback for me at this email. Sorry, the email is not written correctly. It's office@londonfertility.clinic. So please ask your questions or any feedback for my lecture here on this email. Thank you very much. Thank you again, ICOG office bearing seniors and Foxy seniors to give me this opportunity.
Thank you very much, Dr. Chawla. Thank you so much for that enlightening talk. Madam, are we going to be taking questions in the end or what happens?
Yeah, we'll take later. Now we have Dr. Prakash Trivedi waiting to give us his address for 1 minute.
Nice.
Nilima, will you put Dr. Prakash, please?
Yeah, I spoke to sir. He's very much there. Dr. Trivedi, you can hear us. He said he can hear us. Can you please unmute and speak?
Can you hear me now?
Yes, yes, sir. We can hear you. Now we have to just put your video on.
Yeah.
Okay. In any case, I will start my video, but I think so without wasting much time. Fortunately, I was here from 4 o'clock, but there is something which is I connect to everywhere in the world through this same MacBook. Great to be guest of honor, and technical issues will get solved and I'll be seen. More important is I am obliged because commitment of Asha Rao for endometriosis, then ICOG, and all the people behind that is tremendously useful. And currently, even in the endometriosis ESHRE guideline, our entire research has come up. So I will be listening. I will try to see how I join. But I would like to thank and not waste your time. And you can go, and in the meantime, I'll work out so that I am seen. So I don't remain Mr. India.
That's nice. That's very nice way of putting it, Dr. Prakash.
Thank you.
Thank you so much.
Thank you
for being with us and tolerating all the inconveniences.
It's okay. It's part of the thing.
Thank you so much for your blessings. Now let us move to Dr. Jayaprakasham's slide, please. CV. Dr. Jayaprakasham is waiting.
No, I think we have Dr. Asha Bakshi here.
No. That has been changed.
No. Second is Dr. Jayaprakasham.
Jayaprakasham. Yeah. Dr.
Okay.
Devika, will you please introduce Dr.
Yes,
Jayaprakasham? He is already here.
Yes, gives me great pleasure to introduce Dr. Jayaprakashan. He is an honorary professor and consultant gynecologist in reproductive medicine and IVF consultants in University Hospitals of Derby and Burton, University of Nottingham. Published several papers and books, and he's the associate editor of the Obstetrician Gynecologist, which is the RCOG's journal, editor of the Journal of Clinical Medicine, and he's a member of the RCOG's Green Top Guideline Committee, which we all read. And he's an editorial board member of Human Fertility. Over to you, sir, for your talk.
Okay, can you, thank you. Thank you for the nice introduction. Can you see my slides?
Yes, we can see your slides.
Yes.
Yeah.
Fantastic. Okay, thank you very much, Dr. Rao and the whole organizing team for inviting me for this meeting. So my topic is ovarian stimulation protocol in endometriosis. Is it different? I wish I could give you a sort of an answer, but after listening to Anu, and I think it sets a good platform to clarify that, you know, there are a lot of research going on, but unfortunately there isn't a single sort of a magic medicine or magic protocol that I could tell. But we know that the endometriosis is very common and it affects the fertility through various causes, you know, affecting oocyte-sperm interaction, endometrial receptivity, and affecting the ovarian reserve. And IVF may bypass some of these things, but not necessarily all of them. And in general, in IVF, you know, with regard to the ovarian stimulation protocol, it is more or less like a personalized cookery because there isn't much concrete evidence. And I might be probably choosing one which I'm comfortable with and I'm comfortable with my patients, and you would choose a different one. And that is true for the endometriosis as well. So it is not anything different in endometriosis. But having said that, I'm trying my best to go through and probably bore you with a lot of data taken from various studies. And one of them that we have already mentioned about the ESHRE guideline, which has come out in 2022. And the one recent guideline produced by the BFS, a fantastic team, those look through the literature search and have come up with recommendations as well. And I will be using the Cochrane review, the one that is published. And I'm sorry to give you quite a number of things, but this is what I wanted to address. So basically, whether is hormonal pretreatment to IVF helpful with the GnRH agonists, combined pills, or progestrogens, and I think Anu has already alluded to briefly on this. Then whether the agonist or antagonist protocol better, is the progestin primed ovarian stimulation is a good alternative? Any specific gonadotropin that we could recommend? Whether it is better to use a segmented approach with a frozen embryo transfer, whether that offers any advantage over the fresh embryo transfer cycle, and any specific FET protocols, a frozen embryo transfer protocol with a downregulation, and also briefly on the fertility preservation options. So let me just go take you through this. I'm sorry, I can't see the whole. So first of all, whether the ultra long protocol or whether you would give a long-term hormone treatment prior to IVF, whether that offers any improved chance of success. Having said that, the ESHRE has recommended that it doesn't help because the evidence is uncertain. And they made that sort of a statement based on the Cochrane review that is published in 2019. And if you look at the evidence, the Cochrane review, as you are all aware, they will be looking at only the randomized controlled trials. And in fact, for the live birth, they could see only one. And in fact, I couldn't see this paper published yet, but that has been there in the system. And they have shown that, in fact, the live birth is slightly reduced. And if you look at the ongoing pregnancy rate, it hasn't made any difference. And if you look at the mean number of oocytes, it is increased if you use the ultra long protocol. That means at least 3 months GnRH agonist injection. And if you're using the same protocol, that could reduce the number of embryos. So based on that, the conclusion by the authors is the evidence is uncertain. Having said that, there's a subsequent systematic review and meta-analysis which is published in 2021, and they have included some of the studies that have incorporated in the Cochrane review, but they looked at some of the other controlled studies, so not necessarily the randomized controlled, so it is other non-randomized controlled studies. It has shown that there is a benefit overall in terms of the clinical pregnancy, and if you're specifically looking at 3 months downregulation or 6 months downregulation, 7 of those studies have used 3 months downregulation. And again, that has shown that that is beneficial. And 6 months downregulation, there was only one study. And they showed that there is a benefit. Probably there is a trend in, towards improving the clinical pregnancy rate. And they have separated into stage 1 and 2 and stage 3 and 4 endometriosis. And in that, the studies, the study numbers were small, and it hasn't shown any difference. And this has been confirmed in another systematic review and meta-analysis, where they put out only the randomized controlled trials, and that has shown if they compare with the ultra long versus a long protocol, it improved the pregnancy rate. I know it is confusing. And if they have compared with the antagonist protocol as well, and it has shown that there is a benefit. But remember, these are not randomized controlled studies. These are all, this includes non-randomized controlled studies as well. So just to summarize, from that perspective, whether the prolonged GnRH agonist treatment, there are a number of studies, and majority of them has shown that there is no difference. And the bodies like ESHRE and the Cochrane and the BFS have come up saying that they wouldn't recommend using a ultra long protocol prior to IVF. Having said that, there are some systematic reviews which have shown that there is a benefit if you're using it, and they've compared with the long protocol as well as the antagonist protocol. What about using a combined pill for a long period of time? And this is a very nice study, but this is not a randomized controlled study. This is a retrospective controlled study where they used combined pill for about 6 to 8 weeks pre-IVF. And that is a group 1. And the group 2 is they haven't used the combined pill. And they have categorized the patients into endometriosis stage 1 to 2, stage 3 to 4, and presence of endometrioma. And in that, only the endometrioma group, they have shown that there is a potential benefit in improving the clinical pregnancy rate. I've marked here, I'm sorry this is a busy slide, but I just wanted to show that the endometrioma group have had a better outcome if you're using a combined pill for about 6 to 8 weeks prior to IVF. What about progestogens? The people have used the Dynogest, and they used it for about 3 months and then wait for them to have a period and then use an agonist protocol. And in that, one study has shown that the number of eggs have been reduced if you're using a prolonged progestin use. And the pregnancy rate is also reduced if you're using a 3 months worth progestogens. Whereas in another retrospective study, it has shown that there is a benefit. So it is confusing if you're looking at those 2 studies. So just to summarize about using a combined pill, yes, it has shown that there is an improvement in the pregnancy rate in the endometrioma group. And one of the studies showing the progesterone probably not beneficial. In fact, it is detrimental, whereas the other study has shown there is a benefit. And the ESHRE has come up saying that, again, insufficient evidence, and therefore they don't recommend to use this. What about agonist or antagonist? There are a number of studies looking at this, and I will briefly discuss, one or two studies. This is the only randomized control study where they looked at, and they selected patients who have mild to moderate stage 1 and 2 endometriosis, and the resected endometrioma as well as the active endometrioma. And in that, they haven't seen any difference between the two if it is a stage 1 and 2, whereas a resected endometrioma, where they have seen that the better number of eggs, as well as in active endometrioma group as well. But however, they haven't noticed that there is any difference in terms of the pregnancy. And another study showing no difference. So again, if you are summarizing all these studies, it is very confusing. Majority of studies have shown there is no difference, but some of the other studies have shown there could be a benefit. And it's good to note that there wasn't any study that has shown that the long agonist is disadvantageous compared to an antagonist protocol. And the ESHRE has come up saying that the studies have shown there is similar pregnancy rate and live birth rate, and therefore you could use either or. What about progesterone priming? And this was, in fact, if this is an option only if you are not planning a fresh embryo transfer. So instead of an antagonist, this group have looked at, in fact, they use this mainly for fertility preservation. And they have shown that the results are more or less comparable, comparing with the antagonist protocol. And therefore, this is a good alternative. And to reduce the cost, if you are not planning any fresh embryo transfer. And there is another group, they have compared using a medroxyprogesterone acetate versus dydrogesterone versus the natural progestogens, the Utrogestan, and they have shown that there is a subtle benefit in terms of the number of mature oocytes if you're using a medroxyprogesterone acetate, but the clinical pregnancy outcome were similar. What about fresh transfer versus frozen embryo transfer? Because we have heard briefly from Anu about, the estrogen receptors, and if you're using a fresh cycle where there will be high estrogen, and therefore it could be detrimental if you're going ahead with a fresh embryo transfer. And that's the reason why the rationale of looking at this, whether the frozen embryo transfer would offer any benefit. And again, there are a number of studies, and one of the studies, all of them are retrospective, no randomized control study, where they have looked and they have seen that the pregnancy rate could be better if you're using a deferred embryo transfer. That is, you do a fresh cycle, wait for some time, and then use a frozen embryo transfer. And that has been shown both in stage 1 and 2 endometriosis group, as well as a stage 3 and 4 endometriosis group, as well as you see here, the freeze-all approach has improved the chance of success. And in this meta-analysis, it is also shown more or less a similar result. But I would like to reiterate that there are no randomized control trial in this. So this is just a sort of a summary of these studies. Almost all the studies, retrospective studies, have shown that there could be a benefit if you're using a frozen embryo transfer. But having said that, the BFS, the British Fertility Society, has come up with this recommendation saying there is no evidence that freeze-all is better. And they have taken that the studies are not randomized, and therefore the quality of studies are probably not that good. So it was a good practice point. What about frozen embryo transfer protocol? There has been a number of studies comparing the natural cycle versus the artificial cycle and letrozole cycles and things, and there wasn't any difference. But if you're using a down-regulation protocol, more or less in combining with suppressing the endometriosis, and see whether that makes any difference. This is one non-randomized retrospective study, and they have shown that if you're using a down-regulation protocol, comparing with just HRT alone, it has shown that there is a benefit in terms of improving the clinical pregnancy and the live birth rate. And this has been proven in another retrospective study, more or less the same, where they have looked in the endometriosis group, the pregnancy rates were improved if you're using a down regulation before going ahead with a frozen embryo transfer. So just to show you a summary of all the questions that we have asked or we have posed to begin with, this is my second last slide. whether would you use a pre-treatment GnRH agonist or not prior to embarking on IVF? All the international guideline bodies are saying uncertain benefit, and therefore they wouldn't recommend. But having said that, it can be considered after surgery to prevent symptoms and recurrence of endometriosis. And there are some retrospective studies have shown there could be a benefit. What about the combined pill? Again, insufficient evidence, but there is a non-randomized control study showing that if you're using combined pill for about 6 to 8 weeks pre-IVF in endometrioma, there could be a benefit. What about agonist versus antagonist? Categorically, almost all the studies have shown there is no difference, and therefore all the guideline bodies have shown that recommended that you could choose one or the other. Having said that, if you're planning an agonist cycle, maybe you could try a bit more longer protocol, particularly after surgery. But we need to be cautious in terms of women with a reduced ovarian reserve. What about progesterone primed ovarian stimulation? There is insufficient evidence to recommend. However, it showed that similar effectiveness, and it is a good option if you're not planning fresh embryo transfer because it is more convenient and it reduces the cost of the treatment. Any specific gonadotropin? No studies of direct comparison between different preparations. And of course, that the choice depends on the clinicians and the patient's preference. What about the FET versus fresh or frozen? There are no RCTs. Retrospective studies and meta-analysis have shown a benefit towards a frozen embryo transfer. Any specific frozen embryo transfer protocol, insufficient evidence to recommend one over the other. There are studies lacking. Retrospective studies have shown there could be a benefit if you're using a GnRH suppression than with HRT. I haven't shown you about the fertility preservation slides because of lack of time. But I just wanted to summarize that it is an excellent option in terms of people who have been diagnosed with ovarian endometriosis and ovarian endometrioma, particularly if you are going ahead with the surgery. And prior to embarking on surgery, it is recommended to counsel women about the option of the egg freezing. And that is what we tend to do as well. And then in those group of people, it is a good option to preserve a reproductive or to maintain the reproductive outcome, particularly for young women. And thank you for listening.
Thank you. Thank you so much, Dr. Jayaprakash, for that fantastic lecture, which is crystal clear. So many doubts. I wish we had another 15 minutes for you so that we would have been really benefited. And you have finished so on the dot. So we can have a couple of questions. Devika, anything?
I don't think there are any questions in this box right now. I don't know, but that was an excellent talk, and I simply loved your concluding slides because that gave a very, very crisp message. But these are all randomized control trials, non-randomized control trials, etc. What do you do in your own private practice, sir, or in your practice?
See, obviously, I don't specifically separate out from the endometriosis point of view. Of course, that, I tend to do more of a down regulation protocol, I must admit, provided the ovarian reserve is normal. Yeah. And same thing with regard to frozen embryo transfer as well, particularly if there is a presence of adenomyosis and endometriosis.
Yeah. Do you do a long down regulation protocol then before? So suppose the patient undergoes surgery and then you put her on long down regulation and then you wouldn't allow her to have a period and you would continue stimulation.
Exactly. Yeah, that's right. Unless of course, that if they are going for a natural cycle, then yes, you would stop. But if it is going for if they're going for IVF, then I tend to get on with the stimulation with the down regulation. Yeah.
Do you use the progesterone prime cycle often?
No. It is only for people who have got egg freezing. Then yes.
Yeah. Great.
So thank you so much once again.
That's okay, and hope you all have a good day. Thank you very much.
Yeah, and in spite of your busy schedule, you have come in the middle of your consultations. Appreciate very much, and thank you. And let us go to Dr. Asha Bakshi.
Yeah, next chairperson can introduce Dr. Asha Bakshi.
Yeah, so welcome, Dr. Asha, and she is the lead consultant at the Motherhood Hospital with the Infertility Center. Vice President-elect 2022, West Zone Foxy, Joint Secretary Officer in 2020 to 2021, founder chairperson of the MP IAG and MP ISAR, chairperson of the Foxy Infertility Committee, and she's got plenty of awards. She's been
Devika, that's it enough. Thank you.
Okay, right. Over to you, madam. Yeah.
I'll just share my screen.
Welcome to you, Asha.
Thank you. Thank you. I'll just share my screen and stuff. Okay. That's it. So thank you very much to the ICOG, to Asha, to everyone for inviting me. I'll not waste a lot of time, but I'm really thankful to all of you. And actually today only I came from ICOG and somehow I'm managing. So maybe this I could not really revise the talk very well. And I think most of what I am going to talk has been already talked by Dr. Anu and Dr. Jayaprakasan. So just a little bit, infertile women are 6 to 8 times more likely to have endometriosis, and women with endometriosis have lower monthly fecundity, and endometriosis is associated with lower live birth rate. So what comes first is really difficult to know, but yes, there is an association. And the pathophysiology, we all know it could be some sort of inflammatory reaction, it may be some sort of autoimmune response, or there may be some mechanical problem. All these things combine together and they give to infertility. And the prevalence of endometriosis in reproductive age women is 10%, and infertility incidence amongst women with endometriosis is almost 30%, and endometriosis prevailing amongst infertile women is 50%. So these are all the various incidences. And whenever you do laparoscopy, I think in endometriosis fertility index is very important, and we all should try to use it. And here it combines two things. One is the history of the patient, and another thing is the least function score of everything, the tube, the fimbria, the ovary, and all these things are taken together. And this was established by identifying the most predictive variables for pregnancy, and subsequently validated by many other studies, and it really is a very good tool. And it now comes that when a patient has got stage 1 and 2 disease, what to do? So should laparoscopy be done or not? So laparoscopy these days, with such good facilities for diagnosis, does not have much role even in case in stage 1 and 2 diseases. Though there were some studies, some guidelines which used to say that yes, laparoscopic surgery and ablation of endometriosis does improve the prognosis, but ideally it should be done where it is really very much indicated, when there are some other things like you are suspecting tubal problem, or when you are when there is a lot of pain, then in those cases maybe there is a role of laparoscopy. But nowadays people are mostly avoiding laparoscopy, and these are in this Cochrane review, two RCTs were there, and they have compared laparoscopic surgical treatment with diagnostic laparoscopy. And what they found is live birth rate and ongoing pregnancy rates after 20 weeks from both the studies. Meta-analysis demonstrated an advantage of laparoscopic surgery. So there is a weak evidence, even according to ESHRE guidelines, that there is a very weak evidence that laparoscopy is beneficial in cases of type 1 and type 2 endometriosis. And this is what the ESHRE guidelines say. And especially they've said that rather than diagnostic laparoscopy, if at all you have to do, you have to go ahead with the operative laparoscopy. And I think in modern times, there is no role of diagnostic laparoscopy. If at all you have to do something, you should be prepared to deal with the situation as well. And spontaneous conception rates within 3 years after surgery have been reported to vary from 46 to 77%. So there are lots of, most of the times patients really do not want to wait much, though there are hopes that a spontaneous conception may occur. But still, for how long the patient is going to wait? And most of the patients, once they have been coming to us, they are very, very eager to conceive rather than wait for such a long time. But overall, IUI stage 1 and 2 disease should be considered like unexplained infertility. And in that case, IUI is effective. Now, stage 3 and 4 diseases should we go straight away for IVF, or should we try naturally, or should IUI be done? So here again, I think it's very important that you do a good analysis, discuss with the patient, and see what sort of disease is there and what sort of ovarian reserve is there, and then you decide. Many times what happens is the moment endometriosis patient comes, you say you conceive. So then again, it is not that just we are forcing the patient to conceive and then and that is the treatment. So we have to really discuss with the patient what are her plans, how is her ovarian reserve, how severe is the disease, and then consider IVF. But of course, stage 3 and 4, we all know that if we are going to waste a lot of time, then in the future, the AMH will go down, the disease will progress, and there will be further problems. So it is a good idea to suggest ART, but do not force upon the patient. And then again, about excision of endometrioma, already Anu and Dr. Jaiprakasan have discussed that every endometrioma really does not need excision, and you have to analyze. And in my view, you have to excise the endometrioma when it is really large enough that your oocyte retrieval will be difficult, or it is in such a place. Sometimes whenever you go for oocyte retrieval, ovary is just at the back, and it is whatever you use, whatever techniques you use for oocyte retrieval, it is very difficult to do the oocyte retrieval. So maybe such patients, they do require laparoscopic surgery to connect the anatomical axis of the ovary during oocyte retrieval. So here again, laparoscopic surgery is helpful. And or if there is an endometrioma which is suspicious and it is rapidly growing, then again endometrioma excision is an important point. Otherwise, on a routine basis, you do not need to excise the endometrioma. And endometriosis fertility index predicts live births following surgical resection of moderate and severe endometriosis. And it has been found that women with a high EFI score have excellent fertility prognosis and may be advised to try to become pregnant with timed intercourse compared to women with low score, for whom immediate referral to ART is more reasonable. So this is how it works. And can a laparoscopy improve the IVF success rates? So the only indication where there is no controversy is presence of hydrosalpinx, that you excise the hydrosalpinx and then go for IVF, and that's how laparoscopy will improve the IVF success rate. And otherwise, surgical resection of peritoneal disease to minimize the deleterious effect and all those things, the evidence is not there. So, and even presence of endometrioma we have discussed, and we have even deep infiltrating endometriosis also. As such, laparoscopy does not improve the success rate except for hydrosalpinx. And endometrioma, we have already discussed that when there is, it is difficult to access the follicles, and concern that in many a times what happens when you are going to aspirate the follicles, you are afraid that you may go in the endometrioma cyst, and that may contaminate the fluid, and fluid may have deleterious effect on oocytes. And so all these things, so there are lots of confusion, but mostly now things are clear, and routinely there is no need for excision of endometrioma. Now, impact of endometrioma. In this, again, intra-patient comparisons were done with unilateral endometrioma. The number of oocytes retrieved, M2 oocytes retrieved, and total embryos formed were similar. So there is reduction in oocyte numbers when endometrioma is present. Surgery can potentially further reduce the numbers unless the ovarian reserve is very good and endometrioma is large and bilateral. Surgery should be avoided. It does not have much role. But then again, it is individual decision, and you have to take in account other things also. Patient may be having severe pain, and in these cases, you may have to consider. So one thing which people are very much afraid of is, oh my God, I'm doing oocyte aspiration and by chance you have gone in endometrioma and the fluid has come. So you are afraid that, oh, my oocytes will get spoiled or anything. So here this study showed that exposure of oocyte to endometrioma fluid has no impact on fertilization or early embryo development. But one thing is there that there is a point that you can give before oocyte retrieval, you can give antibiotic for surgical prophylaxis, and that's a good idea in such cases. And I think this all we have already discussed, so I'm not going to discuss much about it. Now, coming to ESHRE guidelines, ESHRE guidelines does not support the excision of endometrioma, and according to them, in a review based on combined results of 8 studies, the pregnancy rates after surgery for endometrioma was 43.8%, so there is not much difference. Now, risk associated with cystectomy, I think most important is risk of having low oocyte reserve. So clinicians should counsel the patients well before doing cystectomy. Now, getting to know endometriosis-related infertility better, a review on how endometriosis affects oocyte quality and embryo development. So people say that there may be generation of ROS, dysregulation of immune system, meiotic spindle disruption, and extracellular matrix may occur. So these are few points which suggest that maybe one has to control endometriosis for getting better results. But this is not very well understood. Then few have addressed fertility in endometriosis from embryological perspective. The micrometastasis and all systemic effects may not be eradicated by simply removing signs of disease. So there may be some hidden things along in endometriosis which are affecting the the implantation. So it is not just treating the endometrioma, there may be some other issues as well. So, and endometriosis is associated overall with highly inflammatory pro-angiogenetic environment, and this all can affect the oocyte quality. Those studies have so far not shown that it does affect the oocyte quality that much. Then Dr. Anu has already spoken about the impact of pregnancy or impact of endometriosis on early pregnancy, and there is increased incidence of recurrent pregnancy loss, and even increased incidence of ectopic has also been raised, and there may be chronic inflammation of utopic endometrium along with these patients, and that could be one of the causes of recurrent pregnancy loss or ectopic pregnancy. And even obstetric outcome is affected. That also Dr. Anu Chawla has discussed. So very important that these patients should be monitored well. It does not mean that we should all the time be after them, but we should be vigilant when such patients come. Because what happens is IVF is done at one place and patient is referred to other place for the obstetrics. And in that proper notes are not there that the patient has endometriosis. So whenever you get patients who have conceived through IVF and who have had endometriosis, then I think it's very important that we monitor them in such way, because these patients tend to have FGR, they do have placental abnormalities, and so you should be well prepared and treat them accordingly. So overall, whenever you have infertility patient, you have to think whether this patient needs hormonal treatment, and Dr. Jai Prakashan has very well discussed about it, that only in endometrioma, there have been some reports that combined oral contraceptive pill can help. Then about the surgery that we have discussed, and when assisted reproductive technology, ART can be offered to these patients. And if in surgery EFI score is good, then these patients can go for natural conception. So all these things are important. And talking about the adjunct treatments, I think that also Dr. Jai Prakashan has spoken. Nowadays, people are talking a lot about the use of GnRH antagonist in these patients and use of dihydrogesterone in these patients, which may help in some way. So, and we know that adenomyosis and infertility and endometriosis, they usually go hand in hand, and adenomyosis does have significant role in infertility because of the genetic problems, inflammation, and angiogenesis.
Sorry to interrupt.
Yeah. So I'm about to finish. So this again, Dr. Anu has addressed very well. So I'll just skip it. And frozen embryo transfer has been suggested, but still there isn't any consensus about it. And so basically, infertile women have 6 to 8 times higher endometriosis prevalence, and comprehensive management should be done. The causes of endometriosis, though not fully understood, no curative treatment currently exists. Surgery and IVF are options for the management of associated infertility. Surgery can improve fertility. Diagnostic laparoscopy and imaging along with empirical treatment can be considered for suspected endometriosis. Factors such as age, duration of fertility, ability to undergo IVF, ovarian reserve, male factor, all these things should be considered and discussed with the patient, and then the decision should be taken. So at the end, I would like to thank you all for the patient listening.
Thank you very much, madam. That was an excellent talk. I don't think there are that many questions over here, but I just want to ask you one something that has been bugging me. What is your opinion on Dynogest?
Dydrogest these days people are using like anything. One thing that I like to do about Dydrogest is many people, they are not so keen on active treatment and still they are having symptoms of endometriosis and they are keen on pregnancy, but they don't want active management for infertility. So in these patients, I think it is worth giving Dynogest, because that will control the symptoms. At the same time, it would allow pregnancy to occur. So that is where I like to use Dynogest.
Have you seen any
Dydrogesterone?
Yeah. Have you seen any cases?
Bhagwan ka prasad.
Yeah.
It's like giving a prasad from temple.
Yeah.
Thank you for that wonderful lecture, Asha. Thank you very much. And now we have Dr. Krishna Kumar.
Yeah, welcome, sir. Dr. Krishna Kumar is the Chief Consultant Fortis Hospital. Oops. I think something happened here. Yeah. And he's a past president of the Indian Association of Gynecological Endoscopists. And he is in charge of the IAG cadaver course. And he is recipient of the IMA Award 2019 to 2020. Eminent Medical Men for Distinguished Achievement of Highest Order. We welcome you, sir, and looking forward to listening to your talk.
Thank you. Thank you, Dr. Asha Rao, and all those concerned in the ICOG for having me in this particular ICOG masterclass on endometriosis. And it's a nice concept. And as already told, I'm going to speak on recurrent endometriosis. We have been hearing lecture from quite eminent speakers for the last 2 days, and I would restrict for recurrent endometriosis. Of course, the scope of my talk will include the incidence and the implications of recurrent endometriosis, the risk factors which lead to endometriosis, how to mitigate them, and definitely the management in patients with recurrent endometriosis. Basically, 15 minutes is too short a time. I'll try to highlight basically some of the current concept. And this, of course, we all know surgery has been the standard treatment for endometriosis, but unfortunately doesn't give you complete cure or complete result. It has its own risk factors, we all know, in the form of ovarian reserve decrease. And of course, the symptom may still remain unsolved. And today we have seen in the last 2 decades, the way endometriosis is presenting and the severity of endometriosis is increasing dramatically, and the surgery, of course, we all are rising up to the challenge. And the implication, basically, one has to understand why is recurrent endometriosis important. Of course, definitely women who suffer, definitely their quality of life is interfered in a large extent, and it has its own implications on the reproductive, if they are in the reproductive age group, and can lead to repetitive surgery, very difficult surgery, and finally they'll end up with radical surgery. And today, the surgery difficulties we have seen, I've been witness to that in the last more than 3 decades, where today we have got more and more difficult endometriosis surgeries to be tackled with. So we have a separate concept today. We have a totally endometriotic surgeon, only surgery who specializes in endometriosis, and it's important. Well, if you look at the incidence, it is very depends on whether you take the symptoms of endometriosis like pain or dyspareunia or dysmenorrhea, or you have the clinical criteria, which includes pelvic masses, either clinically or sonography, nodules on examination or imaging, and of course the persistence of infertility. So these are some of the factors which you have to include. The overall literature recurrences, if you look, it varies right from 6 to 67%. And as the period increases, the recurrence rate definitely increases. So one has to modify to our patients that after the end of 2 years, if the patient feels she's symptom-free, you should still keep her on monitoring or on some medication so that at the end of 5 years, she doesn't become more presenting with the endometriosis symptom, because the 5 years in recurrence rate is much, much higher, or almost double the rate than the second year. So we need to keep a proper follow-up. That's what the implication is. And if you look at the recurrence, the pain and pain-related symptoms, recurrence is much more than clinical recurrence. So even if a patient on sonography doesn't have any evidence of endometrioma or endometriosis, but she complains of pain or pain-related symptoms in a patient who has had previous surgery or endometriosis, one has to still consider it as a recurrence. So that's where, again, this is important for as far as this is concerned. Now, what are the causes of recurrence? Either it must be the original lesion was not removed completely, or residual, or rather a retrograde, fresh menstrual cycle going retrograde and starting a de novo presentation, or it could be more in cases where DI is concerned. Lymphatic spread is also considered very, very relevant, could be one of the reasons for causes of recurrence. So these two are the main cause of recurrence. But what is the recurrence chance when you do by laparotomy or laparoscopy? We all today consider laparoscopy as the gold standard in the management of endometriosis, for the vision, for the depth where you can go in and remove, extend all the lesions. But if you look at the recurrence of dysmenorrhea and pelvic pain, both show comparable performance. But if you look at the dyspareunia group, laparotomy group definitely have a higher incidence of dyspareunia, definitely, because to reach that pouch of Douglas area, laparotomy will definitely have its limitation. Laparoscopy, you have today an enhanced view, better imaging system. You can approach those pelvic spaces much better and clear of those areas. So the dyspareunia symptoms are much less. And also patient needing surgery seems to be higher with laparotomy. Repeat surgery is definitely higher with the laparotomy group. So definitely today, laparoscopy is the approach for surgical whenever you decide to do in any patient. Now, the risk factor is something important. Younger the age, a woman getting endometriosis at a young age definitely stands much higher incidence on high revised American RF score. Deep endometriosis, tenderness at the cul-de-sac is again very, very high incidence of recurrence. Bilateral involvement of the disease, and of course, history of surgery is one of the risk factors. We know that in some large studies published by Liu and Lee et al. Now, endometrioma, definitely the left side endometrioma seems to be more chance of recurrence. Presence of bilateral endometrioma, again a higher chance of recurrence. NSS greater than 6 or 8 centimeter, the patient stands to have a higher chance of recurrence. So this is what one has to consider when you see an endometrioma initially and you plan to do a surgery or plan to treat it, whether conservatively or surgically. You have to keep in mind how to mitigate or how to reduce the recurrence in these patients. That is where we as clinicians should work on. We can't just say endometriosis is a sticky disease, it will keep coming. But whatever we have learned in these few decades, we have to put it in practical approach and see that the woman suffers much less than from this dreadful disease. Well, surgery and recurrence. Definitely, we all have heard and we all know completeness of the first surgery is a great prognostic factor. If this first surgery is not complete, the recurrence chances is very high. Whereas if you do a complete surgery, and that's where today more and more surgeons are doing a lot of pelvic peritoniectomy and butterfly technique and everything from the hope that they can remove it completely. 2 decades back, we were told only to fulgurate those endometriotic spots. Today, that doesn't stand as a treatment. We need to have excision of all the endometriotic deposit. Now, preoperative medical therapy before surgery, definitely no, because it may increase the risk of recurrence. Enough studies are there to prove that. GnRH agonist, we all thought could be helping, but does not provide any surgical improvement and did not affect the recurrence rate. So preoperative medical therapy is definitely not needed when you're planning surgery. It may actually be dangerous or harmful because it may mask some of those deposits which you may miss and which may present again. Now, pregnancy has always been considered to be a protective modality from endometriosis, obviously, because the patient stops menstruating for those couple of months, and then postpartum, again, if lactation and other, so maybe 18 months to 2 months, there is going to be no menstruation. So definitely the growth of endometriotic lesions is stopped, and also the higher progesterone levels may be suppressing the inflammation caused by these endometriotic lesions. So any woman who is for reproduction should be encouraged if it is possible, so that at least the symptoms may be, the recurrence may be slightly delayed. Now, post-operative medical therapy and recurrence, how to reduce, or does it really help? There are now a lot of studies which definitely compared with medical users and non-users or only the placebo. Administration of GnRH agonist for 6 months after surgery definitely reduces pain, but at the end of 12 to 24 month follow-up. So patient can remain pain-free for a longer time, but less than that doesn't seem to have benefit. As per the study by G et al., 3 months, even in patients with third grade and fourth stage endometriosis, didn't have much improvement, and definitely the objective disease recurrence is not reduced, but definitely delays the time to recurrence. So that's again important. A patient who is not interested in conception can be put on long-term. And just now we heard Dr. Jayaprakashan talking about giving it for a short course and then taking them for IVF. Now, oral contraceptive pills and recurrence. Definitely, recurrence rate is much lower in patients who were on either cyclical or continuous at the end of 1 year. But 24 to 36 months, the rates did not significantly differ as per the study by Muzi et al. And long-term recurrence rate did not significantly change to post-operative medical therapy. Means the disease, we cannot say it just totally disappears if I'm giving continuous or cyclical OCP pills for long years. The disease continues to grow inside, though the clinical presentation may be hampered or covered. Now, whether this study by Saracchioli et al., where he gave 3 groups, continuous, cyclical, and no group, definitely what he found was the difference between the continuous and the cyclical oral contraceptive usage was not statistically significant, but definitely those who were not taking oral contraceptive pills, the recurrence rate was almost close to 30%. So this is one of the good studies, and you may give cyclical to a patient, but if the symptomatology doesn't seem to improve, then continuous treatment is advocated, and most guideline definitely recommends for at least 2 years period where you should give this simple medication and then evaluate at the end of 2 years the symptomatology and the clinical presentation, clinical findings. Now, LNG definitely has been a big boon, though definitely we know that it reduces the risk after till 1 year, and maybe there is no difference between agonist and GnRH in the short and the mid-term protocol, but for long-term follow-up, LNG definitely scores over GnRH, because we all know that we cannot use it beyond 6 months, whereas use of LNG in patients who do not want reproduction, it's a very, very great alternative. Well, endometrioma surgery and recurrence. Well, excisional surgery has always been proven that it gives a better relief as far as pain-related symptoms. The recurrence chances are always less. So the cyst-wall excision is definitely better than fulguration. Even the pregnancy chances are much better. But we all must take all the surgical steps to preserve the reserve. So this is one of the commonest one where we inject diluted vasopressin in between the two layers and then try to do the cystectomy where you do not damage too much to the ovarian reserve. I wouldn't go on much with this. I'm sure there are other to talk on this. Now, post-hysterectomy, yes, even there is a 10% chance of recurrence after hysterectomy because one feels that if I remove the uterus and ovaries, but if I don't do a radical clearance of all those deposits in a patient who is suffering from deep endometriosis, definitely the patient will continue to have pain and definitely preservation of ovaries. We all know that hysterectomy increases the chances of recurrence of pain-related symptoms with endometriosis. So radical surgery, even when you're doing endometriosis, hysterectomy, and not just a conservative surgery where you just remove the uterus and ovaries and you think endometriosis will dissolve automatically, then definitely you'll be caught on the wrong foot. Well, there are immunological factors and recurrence. The higher incidence of CD15A positive natural killer cells are known to be higher in women who have endometriosis and dysmenorrhea, and estrogen receptor polymorphism. The ER receptor alpha is supposed to be associated with more chance of recurrence. So patients with homozygous ER alpha immunological factor, if you can identify, definitely you can warn the patient she has higher chances. Now, these immunological biomarkers are coming up in a big way, and overexpression of COX-2 is one of the other enzymes which, if determined by the immunohistochemistry, is higher as per the study by Yuan et al. In patients. So these are the patients whom you can warn and tell them for a long-term medical therapy in whatever form they want, and they cannot be just left. So this is to identify those patients who have a higher chance of recurrence. These biomarkers seem to be of great help. Similarly, nuclear factor alpha B or nuclear factor KB, which is again something which is known that highness of this particular immunomarker along with decreased progesterone beta constitute a good marker for ovarian recurrence. So again, this is important because almost 80% incidence is known in these patients. Now, how to manage patients with recurrent endometriosis definitely depends on the age, the reproductive desire of the patient, and the clinical presentation.
So your time is up.
Yeah, just finishing. So for recurrent endometriosis, patient who require oocyte embryo freezing, surgery, pain or clinical presentation, agonist depot followed by embryo transfer. Counseling is important when you're planning surgery in patients, complete surgery and long-term medical therapy, or go for radical surgery if the patient is not for any reproduction. So we have moved from the past to the present where we diagnose by non-surgical method, long-term treatment, ART or single surgery followed by ART, and long-term medical treatment. Thank you for a patient hearing.
Thank you very much, sir. That was a fantastic talk, and I think you drove home a lot of points. We have a few questions, after which I would like to ask one question myself. So the first one is, a patient has a 3 centimeter endometrioma. This is from Dr. Anjali. 3 centimeter endometrioma, 3 years of marital life. Can we give Dynagest? And I'd like Dr. Chawla to talk about this, if she's there.
No, we'll ask questions to
She's
Krishna
there.
Kumar now. Yeah, we'll ask questions to Krishna Kumar. Rest of it can be answered in the chat box.
Oh, okay. So, does this question go to Dr. Krishna Kumar then? 3 centimeter endometrioma with 3 years of marital life. Can we give Dynagest?
No, with 3 centimeter and 3 years married life, I would first counsel her to go for pregnancy first, try naturally rather than starting with Dynagest immediately. If there is no other symptom of endometriosis like pain, there is no point in starting, and we should encourage her to get pregnancy. Unless she doesn't want to go for pregnancy, then only one would consider Dynagest initially.
Okay, the next question is, why do we have more recurrence on the left side?
Right. Now that is a question again, maybe the anatomic physiological consideration could be there because of the presence of the colon on the left side. There seems to be more retrograde flow on the left side, and even the lymphatic seems to be higher on the left side. And these are the two hypotheses which I have come across, which says that the left side is much more.
Okay, there's another one. 27-year-old girl getting married next year, detected with an endometriotic cyst and has been treated with Danages for more than 6 months. And in spite of that, the endometrioma has remained the same size. It's about 3.5 centimeter. Next plan of treatment, please.
No, definitely 3.5 centimeter. I would still continue with Dynogest only because she's getting married, and so she may want to wait for a couple of months or year more, and there is no role for surgery. Even if the size doesn't decrease, at least it is not increasing. So that's again very, very pertinent. You do an ovarian reserve test, and the counselor regarding the possibility if the ovarian reserve is fairly okay, she can wait. If it is diminishing, you can just tell her that there are options of oocyte freezing if she's going to wait further, but no surgery. That is the order of the day.
Okay, one more question. Does medical treatment reduce the size of endometriomas?
I think Anu Chawla is waiting to answer the question.
Oh,
One question.
Sure.
She's
Yeah,
not
I
able to
think
unmute
was-
herself.
Yeah, my mouth was closed by the admin. Okay, no, so the answer, first of all, I would actually request all the participants to keep asking questions. We will answer in the chat. So as many questions as possible are answered. So we will type the answer in the chat box. So the answer to this question would be no. There is no way we can guarantee the prevention of recurrence, especially Dr. Jayaprakashan and I mentioned in the talk, there is no therapy clear-cut fundamentally targeted on the cause because we don't know the cause. So till we are clear about what causes endometriosis, it's impossible to create a medication to prevent recurrence. So the answer is no, clearly. So we will answer the questions in the chat box for all audience so we can answer as many as possible.
Yeah.
You can proceed with
thank
your
you so
talks.
much, Dr. Krishna Kumar.
Thank you.
Anu
That
Chawla,
would be
Dr.
better, so
Devi
we can
Prakasham.
start Dr. Asha second session.
Yeah. And thanks to
That's
Chairperson Dr. Devika for excellent moderation. And thank you.
Yeah, so
You
let
know
me
Dr.
introduce
Hafizur Rahman
the.
here? Is he here? Can you just find out who are the...
Thank you,
Yeah,
madam.
Dr.
Thank you very much.
Hafizur Rahman, are you here?
Who's the next chairperson?
Dr. Ashish Kumar Mukhopadhyay.
Yes, madam, I'm here.
Yeah,
Good
very
evening.
much. Thank you. Welcome, Dr. Ashish. A wonderful, excellent personality and a very good friend. Principal, professor, and unit chief of Gynae Ops of the CSS Medical College, Kolkata. Vice President Foxy. He has been past president of Bengal Gynae Society. Sir, you are welcome.
Thank you.
To chair the session. Dr. Ashok Kumar, are you here, please? Dr.
Yes,
Ashok
madam,
Kumar.
I'm here, madam.
Yes,
I'm
yes,
here.
sir. Welcome, sir. Welcome. Dr. Ashok Kumar, we are very well-known personality, director, professor, and head Department of OBGY, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. So, such a big personality. Dr. Ashok Kumar has been Secretary of ICOG and does wonderful work, and presently is a Vice Chairperson-elect. He's on the editorial board of Foxy also. Sir, you are welcome. Do we have the next chairperson? Dr. Amit Patki, are you here, please? Dr. Amit Patki?
Yet to join. Yet to join.
I think he is not there.
Yeah. So we can ask
Dr. So we can request the chairperson to introduce our speakers. The first, Dr. G. Padamshri.
Yeah. Dr. Ashish Mukhopadhyay, I can start perhaps.
Yes, madam.
Good evening.
Thank you very much for giving me this privilege of chairing ICOG masterclass sessions. And here it is that we are starting the second session now. And the first speaker is Dr. G. Padmashri. Dr. G. Padmashri is a sonologist at Rao Hospital, Coimbatore, one of the key members of the ART team, Rao Hospital. She presented a poster on 3D ultrasound and powered Doppler in HT 2015, Lisbon, coordinator of infertility workshop at Yuva Fox in 2018, coordinator for ultrasound workshop at Yuva Fox 18 also, and speaker in 9th Asian Congress on Endometriosis. So the prolific person knowledgeable on ultrasound, I would like to invite her for her talk. And the topic is adenomyosis, best ways of diagnosis. Dr.
Thank you
Padmashri,
very much.
please.
Thank you very much, sir, for the nice introduction. Let me share the screen. I have to go. It's the middle of the presentation.
Please start from the beginning, madam.
Yeah, just all of us know that
Yes.
adenomyosis is associated with endometriosis in 35.1% of the cases and with RPL in 38.2% of the cases. And it is associated with the previous ART failures in 34% of the cases and with the DAE 50%. Please Punte et al. So this shows the importance of diagnosis of adenomyosis. And all of us know the adenomyosis is due to the presence of ectopic endometrial glands into the myometrial stroma, resulting in the area of hemorrhage and resulting in the inflammatory response, resulting in the myometrial hypertrophy and hyperplasia. You can see the completely altered ecotexture of the myometrium. These pathological changes are shown by certain ultrasound features. In 2015, the Morphological Uterus Sonographic Assessment Group came out with certain signs to describe the features of adenomyosis. Again, it was revised in 2022, and the consensus on revised definition of MUSA says it can be categorized into direct features and indirect features. Direct features are due to the presence of endometrial glands in the myometrium, whereas indirect features are due to the inflammatory response of the myometrium to the endometrium, resulting in myometrial hypertrophy and hyperplasia. Let's see the direct signs. Here you can see the TV ultrasound here. You can see the altered ecotexture of the myometrium, and you can see the anechoic spaces here. These are nothing but myometrial cysts, and you can see categorically the echogenic rim, and it contains anechoic fluid, or sometimes it can contain mixed echogenic fluid or internal echoes. And you can differentiate this myometrial cyst from vessel by using color Doppler, and it will not be in continuation with the endometrium. So once you identify myometrial cyst, it goes in favor of adenomyosis. Next is wherever you see the endometrium gland, it is depicted as echogenic area. As you see here, you can see the echogenic spot. But once it infiltrates junction zone, you can see the echogenic line extending into the myometrium. Characteristically, it is perpendicular to the endometrial line. So this is called echogenic line. And when the endometrial glands proliferate, it forms buds. You can see the 3D HD-like image, the echogenic bud. So these are the direct signs of endometriosis, and this will be in continuation of the endometrium. Next direct sign will be the islands, echogenic islands. When the endometrial glands proliferate, they become a nodule. You can see here the altered ecotexture of the myometrium. Multiple nodules are here. This could be single or multiple, regular or irregular, and it will not have any connections with the endometrium. So this again is a direct sign of adenomyosis. So in adenomyosis, there is hypertrophy of the myometrium parallel to the trajectory of the endometrium anteriorly and posteriorly. But if it expands throughout, like length, breadth, and width, it results in a spherical enlargement. So this gives a globular appearance of the uterus. So this globular uterus is again an indirect sign of adenomyosis. When there is myometrial hypertrophy, there is asymmetry of the myometrium. The thickness between the two is more than 1 or less than 1 ratio, or if the difference is more than 5 millimeters, you can term that as asymmetry. That is an indirect sign. And next important sign is the fan-shaped shadowing. You can see the linear striations, hypoechoic and echogenic line spreading across the myometrium, resulting in Swiss cheese or rain in forest appearance. So this is typical of adenomyosis. And Whereas in myoma, you will have the edge shadowing. So this helps us to differentiate from a myoma. And again, if you see here, the power Doppler compared to color Doppler, it picks up even smaller vessels. You can see the translesional vascularity and traversing through the lesion perpendicular to the endometrium. Again, this is a sign of adenomyosis. And whereas in myoma, you will see the circumferential flow. So the fan-shaped shadowing and the translesional vascularity go in favor of diagnosis of adenomyosis. And we come to the endomyometrial junction. You can see here beautifully the hypoechoic area around the endometrium. This is called the normal endometrial junction. Whereas in case of infiltration of the junctional zone, you will see the ill-defined endomyometrial junction. Let's see the role of 3D ultrasound in the evaluation of adenomyosis. Actually, it serves as a missing link between reproductive disorders and major obstetrical disorders. So how does it look normally? By 3D ultrasound, the advantage is you can see the lateral border and the fundal aspect in the same plane, unlike the 2D, and it appears as a hypoechoic area around the endometrial cavity. And the advantage with 3D is you can assess the anterior, posterior, and fundal aspect of the junctional zone in a single plane 3D multiplanar view. So regarding the thickness, what is the criteria to diagnose? If the maximum junction zone thickness is more than 8 mm, or if the difference is between minimum and maximum endometrial thickness is more than 4 mm, or if the ratio between the two is more than 50, then you can call that as an increased junctional zone thickness. But in the latest consensus on revised statement by MUSA, it says thickness has currently no role in clinical practice. So what is the junction zone abnormality? This again is an indirect sign. We have seen in the previous slide the normal outline of the endometrial cavity. You can see the serrated appearance or the irregular appearance. You can see the 3D coronal view, irregular appearance of the junction zone. So this is an indirect sign. And again, we have seen the normal endometrial cavity continuously. But here, if you see any interruption in the junction zone, that is an indirect sign. It could be less than 50% of the junction zone or more than 50% of the junction zone involvement. Here you can see the more than 50% of the junction zone involved by the interrupted junction zone by the echogenic islands and cystic areas. And again, you can see the completely obliterated cavity. So 3D ultrasound can assess the severity of adenomyosis. The junction zone involvement is a feature of early adenomyosis. Again, if you compare between 2D and 3D, 3D ultrasound has a higher sensitivity in the detection of adenomyosis, says the meta-analysis published in 2018. And more the number of features, less will be the chances of reproductive outcome. So 42.7% clinical pregnancy rate if the woman doesn't have any adenomyosis. It came down to 22.9% with 4 features, and further it came down to 13% with all 7 features. So more the number of features, less will be the reproductive outcome. We have seen about the diagnosis of adenomyosis. Let's move on to the classification of adenomyosis. There are multiple classification systems available. None has been universally adopted and validated. And in 2019, Vandenbosch et al. And team brought out reporting system for diagnosing adenomyosis. It says if you diagnose adenomyosis, you have to specify the location and differentiate the types and also the extent of the layer involvement and size of the adenomyosis. Like fibroid, we can map the adenomyosis like anterior, posterior, lateral, right lateral, left lateral, or fundal. And this helps us to evaluate the progression of the disease. You can see the large adenomyotic lesion here, but exact location is not very clear. So the moment you turn on 3D ultrasound rendered image, you can see the large adenomyotic lesion occupying the fundal aspect. This could be more useful in case if the patient goes in for surgery. And again, by using volume contrast image, you can see the endometrium here. This is the uterus. The right lateral wall of the myometrium is completely occupied by the adenomyosis, pushing the cavity to one side. And again, you can see the 3D coronal view showing the serosal involvement of the adenomyosis. So what are how do you describe the types of adenomyosis? focal adenomyosis 1, if more than 25% of the lesion is surrounded by the normal myometrium. But only if less than 25% of the lesion is surrounded by normal myometrium, then you can term that as a diffuse adenomyosis. Why is it important to differentiate between focal adenomyosis and diffuse adenomyosis? Because diffuse adenomyosis is associated with a poor pregnancy outcome, and if the larger lesions of adenomyosis carries a higher miscarriage rate, and also the incompetency rates are higher in pregnant women. And another entity is adenomyoma. If you see focal adenomyosis, and if it is surrounded by the hypertrophied myometrium, then it is called adenomyoma. And most of the time in adenomyosis, there is a thickened endometrium. If you look carefully, you can see the 3D rendered image, and there is a polypoidal projection. So once you identify the lesion, histoscopic polypectomy can improve the endometrial receptivity and also the reproductive outcome. Let's assess the severity of adenomyosis. So how do you assess the severity of adenomyosis? If the uterine corpus is involved by adenomyosis in less than 25% of the cases, it is called a mild variety, and 25 to 50% of the uterine corpus is affected by adenomyosis, that is moderate. More than 50% is severe type. And we should also specify whether inner myometrium is involved, middle or outer myometrium is involved, or all the layers are involved. And this is another case of adenomyotic cyst. In the myometrium, you can see the cystic lesion with the echogenic rim. How to differentiate between ovarian cyst and adenomyotic cyst? Once you apply flow pressure, the cyst moves along with the endometrial cavity. You can see the cyst with the internal echoes. And the next sign of adenomyosis is the question mark sign. This is an important sign because of the adhesion. In case of antevoted uterus, you can see the endometrial cavity being retroflexed, pushed backward, and this is giving a typical question mark sign. So this carries a higher specificity of 93% for diagnosing adenomyosis. What else should we know about adenomyosis diagnosis? Capron et al. In 2017 came out with theory of outside to invasion theory, resulting in focal outer adenomyosis. It could be anterior or posterior. As you see it here, there is an endometriotic cyst, serosal involvement. You can see the altered echo texture in the outer myometrium, resulting in a posterior form. And there will be negative sliding sign because of the serosal involvement. And again, you can see the focal adenomyosis in the anterior myometrium. This is called anterior form. And some authors describe, you can see the focal adenomyosis involving the junction zone is internal adenomyosis, and the serosal involvement is more, this is called an external adenomyosis. And what is the other use of ultrasound? 3D ultrasound can accurately assess the volume of the uterus involved with adenomyosis. It gives a precise quantification of the uterine volume. So it can be used as a guide to plan ultralung suppression before ET. Not only that, it can assess the effectiveness of the medical therapy. And in 2016, Akkar et al. Came out with a elastography application to diagnose adenomyosis. Because it has a heterogeneous echo texture, it shows all the colors like red, green, blue. But whereas in the myoma, it is a firm tissue, it is depicted as a blue in color. This is a meta-analysis published in 2021 with 32 studies, which compared MRI and transvaginal ultrasound for the detection of adenomyosis. It says comparable detection rate between the two. So of course, MRI may add information and increase diagnostic performance in difficult cases, especially with the coexistence of lesions such as fibroids. Case Vandenberg et al. In 2018. To summarize, there are direct signs and indirect signs to diagnose adenomyosis, and the uniform reporting and classification system could be useful, and both the higher end ultrasound machine and high level of expertise will optimize diagnostic accuracy. Thank you for the patient hearing.
Madam, please stop share.
Hello.
Thank you, Padma Shri, for that wonderful presentation. Very clear
Thank you.
presentation. Very nice. And I'm sure Dr. Mukhopadhyay.
May I request now, do we, Asha, we have a time for questions, or we invite
No,
Dr.
no,
Ashok
questions
Kumar?
after. We'll take after three speakers.
So I think I will invite Professor Ashok Kumar for the introducing the next speaker. Hello, Dr. Professor Ashok Kumar, are
Yes,
you
madam.
there? Yes.
Yes, madam. So,
Yes.
good evening. And first of all, thanks for the opportunity to be a part of this mega webinar. And thanks, Dr. Asha Rao, Dr. Kiran Pandey, madam, and ICOG. So, our next speaker is Dr. Asha Rao. And she doesn't need any introduction at this stage. Everyone
very right.
is
Yeah.
she's well known to everyone. However, to complete the formalities, she is a director of Rao Hospital in Coimbatore, director for postdoctoral fellowship program in reproductive medicine and endogynecology, and it is affiliated to Tamil Nadu Dr. MGR Medical University, Chennai. She was chairperson of Endometriosis Committee of
Yeah,
Foxy.
I think that's enough. That's good enough. Thank you.
So
you're right. Everybody knows her.
Because time is a precious commodity today. Thank you so much,
Yeah.
Dr. Ashok Kumar, for being here.
Dr.
In
Asha Rao,
spite of
Dr.
your very
Asha
busy-
Rao, yeah. So, madam, but still, there are few things which I would like to add here. Although you will be talking on optimizing fertility in adenomyosis today, but I think you have authority on overall on the topic of endometriosis, and you have done a wonderful job as a chairperson of Foxy Endometriosis Committee, and that legacy is being now continued by Dr. Anu Chawla, and we are wishing her also good luck for her all future endeavor in this program. So, madam, you can present your topic.
Thank you so much, Dr. Ashok Kumar, for those kind words. Let me share the screen. Thanks to ICOG committee for having given us this opportunity to conduct the so-called mega educative program, the certificate program for endometriosis. Thanks to Dr. Parul and Sarita. And endometriosis and adenomyosis, I'm very passionate about. My journey into adenomyosis started way back in 1993, I would say. My patient was 90 kilos, 34 years, but married for 18 years. She came with infertility and severe dysmenorrhea. And yeah, I can't see the timer somehow. She was married for 18 years, but she was 34 years. And her laparoscopy showed globular enlargement of the uterus with tubal block. And there was nothing that we could offer in 1993. We put her on danazol for 4 to 5 months. And when we stopped it, she promptly conceived. And the baby that was born in 1994 today is 30-year-old young woman, busy executive, and we're also happy about it. So historically diagnosed by histopathology at hysterectomy, adenomyosis today is seen more and more in younger women. Earlier we said it is a disease of 40 women 40 plus and fertile, but today it affects 30% of young women and seen in 22% of infertile women less than 40 years undergoing ART. Is this because we have shifted our fertile years from 20s to 30s or late 30s? That could be one of the reasons. Or we also the better diagnosis, and perhaps both. So apart from dysmenorrhea, menorrhagia, today infertility and recurrent implantation failure, pregnancy loss are considered as one of the important features of adenomyosis. So whenever you see these problems, halt and proceed, look for adenomyosis, and then go further with recurrent implantation failure or recurrent pregnancy loss. 21% of women with endometriosis could have adenomyosis, and 28% of subfertile population has adenomyosis alone, and 30% of these women could be also asymptomatic. And how does it affect fertility? Poor implantation, poor placentation leads to infertility, miscarriage, preterm labor, preeclampsia, IUGR, fetal malpresentations, cesarean sections, NICU admissions, placental problems, PPH, cesarean hysterectomies, you name it. All the obstetric complications can be caused by adenomyosis apart from infertility. According to Salim et al., the pregnancy rate in adenomyosis was 22% compared to 47% in non-adenomyotic women, with high miscarriage rate of 50% in adenomyotic women. And Dr. Padmashri has already told us about the junctional zone and the adenomyosis. And we know that there is benign invasion of endometrium into myometrium, along with uterine enlargement with hypertrophic hyperplastic myometrium. It can be focal or diffuse. And let us see why it happens. The most important feature is there's a problem with the endometrial level itself. There is increase in the factors adverse to implantation, like CD68, natural killer cells, macrophages, and the factors which are favoring implantation, like HOXA10, HOXA11 mRNA, and beta integrin are decreased in the endometrium of women with adenomyosis. And there is thickening of the junctional zone, myohyperplasia, uterine enlargement, and all these lead to excessive uterine contractions causing pain, severe pain, dysmenorrhea, and even pregnancy loss, shown by this wonderful paper by Hashimoto et al. And how to help these women when they come to your doorstep seeking a baby? Is it surgery, medication, or ART, or a combination of three? Depends on the age of the woman, desire for fertility. ART, the surgery is being practiced almost from 1952. Multiple methods are being, the technique is being improved every day. We do see pregnancies, but very quick recurrence, adhesion formation, and 6 to 6.8% chances of 6.8% chances of ruptured uterus during pregnancy. So this is why we are always worried about doing adenomyomectomy unless it is really, really essential. So most patients we can manage with medication and ART. Talking about medication, you have NSAID and OCP only as temporary measures in small adenomyoma. Women who do not want fertility, you can give OCP. Danazol was a wonderful medication in the yesteryears which lost its popularity because of androgenic side effects. Today we have GnRH analog, Dynogest, aromatase inhibitors, GnRH antagonists, intrauterine system with progestogen, ART, and surgical option is only the last resort. The challenge here, it's a real challenge to get them pregnant and have a live birth. So it's very important to have early diagnosis and volume reduction. So do not wait until they are so large and diagnosed by 2D ultrasound. Diagnose it early with 3D ultrasound. You can see here the focal infiltration of the beautiful junctional zone you can see here. And this is a focal adenomyosis. If you diagnose this early, perhaps they may even have a normal pregnancy. You give them a fertile period or IUI, or you can suppress them temporarily for 3-4 cycles and maybe they will conceive spontaneously also. So early diagnosis is very important if you can. And how does GnRH agonist work? It causes hypoestrogenism, suppresses the adenomyotic inflammation. I'm not able to see the timer anywhere. Oh yes, I can see it now, yes. It reduces the expression of aromatase cytochrome P450 in the utopic endometrium of women with adenomyosis. It reduces the size of adenomyoma and uterine volume, both. So after 2 to 6 months of GnRH analog, the uterine volume significantly decreased from 180 ml to 86 ml in a paper by Zhu et al. So it's a medical adenomyomectomy compared to surgical adenomyomectomy. So it's a scar-less, blade-less adenomyomectomy. And New et al. Found that a long course of downregulation led to significant improvements in pregnancy rate. With pre-ART GnRH suppression, the pregnancy rates went up to 51%, and without GnRH, it was 24%. Once again, implantation rate increased from 16 to 32% with GnRH suppression, and ongoing pregnancy rate also went from 21 to 48%. At the same time, the number of days of ovarian stimulation and the cost could be higher in these women with prolonged suppression before ovarian stimulation. And in Park et al. Paper, the clinical pregnancy rate was marginally different, 25 and 30%. So today, more and more, we are trying to avoid ultra-long protocol because it does not do well in women with poor ovarian reserve. Increased cost, decreased number of oocytes, sometimes cancellation of cycles. So we try to avoid ultra-long protocol because the short protocols are working very well. So you can use either an antagonist protocol or a luteal agonist protocol. They work well. It is advisable to do segmentation of IVF. Freeze the embryos, then suppress the adenomyosis for 3 to 6 cycles as per the size and symptoms of the patient. And then do the embryo transfer. You will have wonderful success and live birth. And this is the beautiful paper you can see here. Fresh embryo transfer without GnRH analog, the pregnancy rate was 25%. Fresh ET with GnRH suppression, 30%, whereas frozen embryo transfer with GnRH analog pre-treatment group, the success rate was 39.5, 40%, which is very impressive. So do not go on suppressing the patient, use short protocols and then suppress the adenomyoma, do embryo transfer, you will succeed. And uterine volume seems to be important. The uterine volume is more than 98 cc. The chance of live birth are lower, 25% compared to 43% if the uterine size is lesser, with a higher incidence of miscarriage if the uterine volume is more than 98%, according to C et al. In 2021. This is one of our patients who had adenomyosis. You can see posterior wall 4.7 centimeter, impinging on the endometrial cavity almost. Many times when I ask in a panel discussion, they all say they want to do adenomyomectomy because it's impinging on the uterine cavity. But this lady already had one laparoscopy and failed IVF elsewhere, slightly smaller ovaries. We short protocol, embryo freezing, followed by suppression for 4 months with GnRH analog, embryo transfer, and she conceived first shot. And now she is a happy mother of a 5-year-old child. So again, medical adenomyomectomy. Dynogest, it is very good for control of pelvic pain, but not so good for volume reduction. You can see here a paper by Matsushima et al. They compared GnRH analog, low-dose estrogen progesterone, and Dynogest, a 16 weeks of therapy with GnRH analog. Before treatment, 307 cc, and after 16 weeks, 177. Almost 45% reduction in volume, which is so impressive. Whereas with the other two, with the OCP or Dynogest, you can see there was no change in the volume at all. So that speaks for the benefit of GnRH in the ART clinic. Aromatase inhibitors are also good. They are the second generation medication only for resistant cases. You can use it along with GnRH. Letrozole, I use 2.5 milligram twice daily, along with norethistone to prevent the bone loss and cyst formation. A combined use of aromatase plus GnRH, reduction in uterine volume of 60% was observed after 8 weeks of treatment by Kimura et al. So reduces the adenomyoma volume and symptoms also. Paper by Scarpellini et al. Aromatase inhibitors plus GnRH analog, success rate was 48% compared to 20% with pre-embryo transfer Dynogest. So again, it speaks for GnRH analog plus aromatase compared to Dynogest. This is our patient at Rao Hospital. You can see 2020, she came to us in the COVID year. Uterine volume 344 cc. The normal volume is 60 to 70 cc. Her AMH was 1.26. So went in for a short protocol, embryo freezing. Very tempting to do an adenomyomectomy, but we suppressed her during the COVID year from February to October, 7 months, with 2 doses of 11.25 and another 3.7, along with letrozole and norethistone acetate. Uterine volume came down to 204 cc. Embryo transfer she conceived, and today she is a happy mother of a 4-year-old child. This is early pregnancy. You can see the thick myometrium. Later during pregnancy, it is thinning out, getting better. This is a prognostic sign, and she did very well. LNG IUD also can be used along with GnRH analog. We use it for women with large uterus and a long uterine cavity with thick endometrium. it gave us very good results in these patients for ART. This is one of our patients who is 39 years old, infertility of 15 years, previous failure of adenomyomectomy and ART elsewhere. In view of poor ovarian reserve, we went in for egg donation, suppression for 6 months with the help of GnRH analog, embryo transfer, she conceived twins, and this was 2007. The boys are today 17 years. This is another lady who had recurrent miscarriages earlier. She had failed with 2 ARTs. This lady, after 2 ART failures, we did adenomyomectomy and then did the IVF ET. She conceived and twins were born. You can see this is a cesarean section. The uterus looks very good, very smooth, no indentation, no adhesions, etc. This is post-cesarean on the table. So Rao Hospital, we presented a paper at FIGO in 2019 with 44% pregnancy rate and 68% live birth rate. We have another paper published in Curious last year, fertility and obstetric outcome with ART and GnRH analog in adenomyosis, where we have shown very good pregnancy rates with GnRH analogs. So who is benefited by surgery? Only if the adenomyosis is large, recurrent miscarriage or recurrent implantation failure, not respond to medication, you should do surgery, not otherwise. You can do a medical adenomyomectomy because I said the scar rupture could be sometimes 6.8%. So this is the last slide. To conclude, when women come to your doorstep seeking fertility, do a routine infertility workup, including measurement of ovarian function, semen analysis, and if the tubes are patent, good male factor, give them a chance to conceive like anybody else. No pregnancy, suppress for a few months with GnRH, and maybe there is a spontaneous conception. If she does not conceive in spite of that, you can take her for ART, collect the embryos, freeze them, give GnRH analog, then do embryo transfer, you may succeed. If there is recurrent implantation failure or severe menorrhagia, dysmenorrhea, not responding to medication, that's the only time that you have to go in for surgery. So coexistence of adenomyosis and endometriosis may have significant impact on fertility, which may lead to worse reproductive outcome compared to endometriosis alone. Pre-treatment with GnRH appear to be beneficial, but kindly give it before embryo transfer and not before ovarian stimulation. The benefits of fertility-preserving surgery for adenomyosis vary greatly, to be performed only in selected patients who have severe pain symptoms, failed medical treatment, and IVF, who have focal type of adenomyosis, and maybe even, but do it sparingly and in expert hands. So thank you all for a patient hearing.
Excellent, Dr. Asha Rao. Dr. Ashok Kumar, your...
Yes, yeah, thank you, Dr. Asha. It was a great presentation and you really highlighted the fertility issues and the role of each medical treatment, each drug, how much it is effective or not. I just, can I make a question also here? Can you just highlight, because Dinojoster is very much propagated commercially nowadays as a non-invasive therapy, like no injection, it is oral tablet. So one is how long you can give, because there are studies about giving up to 5 years. The second is how much it really improves the fertility.
Dinojost is useful for women who do not want fertility now. Maybe the lady wants to have a baby later, and she wants a pain relief and it's mild adenomyosis. You can use Dinojost. Basically, it acts by pain relief, and reduction of uterine volume is very much less. This is what the papers have shown. So after childbirth of this adenomyotic lady, perhaps you can put her on Dinojost or even intrauterine device. So Dinojost is for pain relief and not for fertility seeking women. It will not do volume reduction.
So I think there are no more questions, so we can move on. Or of the other questions, they can be put into the chat box, and Dr. Asha will
I can answer in the chat box. Let us go ahead with Dr. Sarita.
Yeah,
Yes.
so let's go for it. Now Dr. Sarita again doesn't require
Yes.
any
No, no.
introduction, but Dr. Ashish, you also have the privilege of introducing.
Let me have the privilege of introducing Dr.
Yes.
Sarita Valera.
Definitely.
Isn't it? So after an exhaustive talk by Dr. Asha Rao, excellent lecture. And before we go into the surgical treatment, I would like to introduce another problem in adenomyosis, that is managing AUB. And who can do it better than our Dr. Sarita Valera? Can we have the CV of Sarita, please? My dear friend Sarita.
Yeah, thank you. I'm here.
Oh,
Should I share the screen?
1 minute. So the introduction is not yet over. I wanted to see your slide. So the hospitals that you are attached with, Bhatia, Saifi, Reliance Foundation Hospitals and Bridge Candy Hospital, Mumbai. That's half of Mumbai, I believe. And she is the running secretary of ICOG and chair WZ India Representative Committee of RCOG. She has been the president of MOGS just 2 years ago, joint secretary of FOXI 2017, and she has served as the chair of FOXI Quiz Committee 2009 to 2011. That's only a brief part of Sarita, very sweet, charming lady with a lot of academic knowledge and other things. So, Sarita, I would like to invite you to have your lecture on AUB in adenomyosis. Sarita.
Thank you, Dr. Mukhopadhyay, for that very kind introduction. And at the outset, let me thank Dr. Asha Rao, Dr. Parul Kottawala for giving me this opportunity to speak in this program. Are you able to see my slides?
Yes.
Yeah, is it in slideshow?
It is not in slideshow, it is in
Yeah.
slide sorter view. So make it slideshow.
No. I've made it slideshow from my end. Now is it in
Okay.
slideshow?
No,
No,
not yet.
madam, you have to, I think, redo it because they are seen in other pattern.
Okay, 1 minute. So now I'm see in mine it is in slideshow. Is it in slideshow now?
Share map और आपको फिर से
Okay, 1 minute.
You can enlarge the.
No, I'm stopped sharing. 1 minute. I've stopped sharing. Now I'm going to share. Yes, I'm going to share again. And now I'm sharing again. And now I'm putting it into slideshow. Is it now?
Dr. Sarita, it is still in the slideshow. That,
No.
different. That slide system pattern.
Slide sorter view.
Yes, ma'am. अपना stop share करिए. उसके बाद
Yeah.
आपको
1 minute.
slides वाली slide दिखाई देंगी जब आप
Yeah,
share
1 sec. So I'm stopping the slide. Stop the slide sharing. Now you want me to share screen again?
Yes, ma'am.
Yeah. So I'm slide sharing, and now I'm going into my presentation, and now I'm in slide sorter view, and now I'm going into slideshow.
No, ma'am. Yes.
Yes, it's happening.
Yeah. Is it fine now?
Yes, ma'am.
Yeah.
It's
So
almost there. Almost there. Just make it full screen.
Yeah, it is full screen from my end. I don't think I can do anything more than this. Yeah, so but you can see the slides, right?
Yeah, we can.
Yeah. So thank you very much, Dr. Parul and Dr. Asha, for inviting me to speak. And thank you, Dr. Ashish, for that kind introduction. My topic for today is AUB and adenomyosis. And, adenomyosis, as the previous speakers have said, is a poorly understood condition and very difficult to standardize treatment. The debilitating symptoms include heavy menstrual bleeding, pain, chronic pelvic pain, dysmenorrhea. And treatment options are vary from expectant treatment in asymptomatic cases to medical and surgical treatment. But hysterectomy is the only definitive treatment. And we need to individualize treatment, as Dr. Asha Rao said very beautifully, based on the age, parity, and the desire for menstrual and reproductive function. And very important for my talk is to understand the etiology of adenomyosis. And we still don't know what is the...
But slides move नहीं होती है.
See, it's moving from my end. Can you see?
No, ma'am.
My God. Okay, 1 minute, just 1 minute.
Yes, now it is moving. Now
it is moving? Okay.
Yes.
Yeah, so the exact etiology of is uncertain, and it is an abnormal implantation of endometrial tissue into the myometrium. Maybe it is invagination of the endometrium. Maybe it is also metaplasia of the stem cells. Maybe there is genetic or epigenetic origin. But what we know is that it is an estrogen responsive condition. And it is this intracellular estrogen production which is leading to this inflammatory, fibrotic, and endometrial-like tissue. So the AUB in adenomyosis is typically heavy menstrual bleeding, prolonged menses leading to anemia, sometimes very severe anemia, also accompanied by dysmenorrhea and chronic pelvic pain. And we have to address all these together. And what is our goal of treatment? Our goal is alleviation of symptoms to halt and reverse the adenomyotic process and fertility wherever required. Can you hear me? Is it fine? Hello? Can you hear? Yeah, it's fine.
Yes, madam, we can hear you very much.
So the first line treatment is the role of non-steroidal anti-inflammatories, which provide symptomatic relief, but we must understand that they have no effect on the adenomyotic process. They are useful for dysmenorrhea. They work by decreasing the production of prostaglandins. Combined with tranexamic acid can be used to control heavy bleeding. But just for a comparison, what studies have shown is that with NSAIDs and with tranexamic acid, the reduction in blood loss may be 20, 25 to 30%. With OC pills, it is 50%. And with the LNG IUD, it is 80 to 90% reduction. So we need to understand and counsel the patient that this is what we are going to expect. With oral contraceptive pills, they induce regression of adenomyosis. They will improve the symptoms of menorrhagia and dysmenorrhea, but the effect is temporary while they are on the pill. And the compliance, we all know our patients over long term is poor. They don't take it for very long. And the side effects may limit their use in the age group above 40 years. That is the limiting factor. GnRH analogs cause regression of adenomyosis very beautifully. What has been used is leuprolide acetate, triptorelin, and gosrelin. But the adverse effects limit their long-term use because of bone loss. So for short-term use, they are very good. And for adenomyosis with infertility to reduce the volume, they are very good. And they can be used before laparoscopic surgery, even after laparoscopic surgery, to reduce the surgical difficulties and reduce the blood loss. Now, the LNG IUS, I think, has been a milestone change, and it has really brought about a change in the way that we treat adenomyosis. It causes decidualization and atrophy of the endometrium, downregulation of the estrogen receptors because of high progestin release, bleeding patterns improve, hemoglobin dramatically increases, and slowly we find decrease in the number of bleeding days in a month, decrease in the amount of bleeding, a reduction in uterine volume, and a significant improvement in pain score, but at 3 months. So it is a highly effective option for the management of adenomyosis. And today, the NICE guidelines UK says that we should consider LNG IUS as the first treatment in women with heavy menstrual bleeding and suspected or diagnosed adenomyosis. So way back in 2015, Shaban et al. Did a randomized trial, and they compared the LNG IUD versus the low-dose oral contraceptive pill in 62 patients. They looked at the uterine volume and the intramyometrial Doppler, and they found that both the LNG IUS and the combined OC pill decreased the pain and the menstrual bleeding associated with adenomyosis. But the LNG IUS was more effective than the combined OC pill, and this effect may be secondary to a decrease in the uterine volume and the increase in blood flow resistance. Then we had Osder Gimenci, who came in 2011 with fertility sterility, who did 75 women, did a prospective trial, confirmed adenomyosis on TVS and MRI, and said that he compared it to hysterectomy and said that the hemoglobin levels at 6 months and 1 year with LNG IUS is comparable to hysterectomy. The quality of life is comparable, and this is a very promising alternative to hysterectomy. Now, Abbas and all did a systematic review in 2020 with 10 prospective studies and said that there's a significant reduction in pain score, but it starts at 3 months, so we have to be patient. It persists at 36 months. There's a significant reduction in heavy menstrual bleeding, a reduction in uterine volume at 12 months, and a very significant hemoglobin increase. And I found this very nice study from Gupta et al. From Delhi, who looked at 40 women And they also said the same things, that there was significant improvement in dysmenorrhea and hemoglobin and heavy menstrual bleeding. But the troublesome side effect in almost 65% of their patients was this prolonged vaginal spotting. So I think that we need to counsel our patients with this. And the success of the LNG IUS was 82%, saying that maybe 20% of patients will not accept it and go for something else. A lot of talk has been said about Dynogest. Dynogest is a synthetic oral progestin, as Dr. Ashok Kumar said, very attractive because it is oral. But studies have shown that the uterine size and adenomyotic lesions do not decrease significantly over short term. It may take long-term use. And metrorrhagia and hot flashes can be troublesome. And compared to triptorelin, Dynogest was inferior in decreasing uterine size and achieving amenorrhea. Aromatase inhibitors are promising. They halt the production of progesterone. GnRH analogs and aromatase inhibitors are equally effective in reducing adenomyosis. I must tell you that this is an off-label use of aromatase inhibitors. Oral letrozole 2.5 milligrams per day can be tried. And Kimura et al. Combined aromatase inhibitors and GnRH analogs and showed an almost 60% reduced uterine volume at 8 weeks, which is really very promising. Ulipristal acetate has been used primarily for fibroids, but studies have shown that it progression of adenomyosis in cases where there are concurrent fibroids. So we have to be very careful when we give it for fibroids that there is no adenomyosis, and there's also a risk of liver injury. So at the current moment, it is not recommended. GnRH antagonists we don't have available to us, but we have a nice talk in our course on it. And linzagolics and elagolics may again change the way we look at adenomyosis in the future because they reduce the lesion size, they improve dysmenorrhea and the quality of life. Now, surgical management is the mainstay also. Here we have to decide whether the patient has diffuse adenomyosis or it's adenomyoma. And our choice is between hysterectomy or a uterus sparing resection. Hysterectomy, there's no doubt, is the definitive treatment and removes the pathology. When other conservative treatments have failed, it is the option can be done vaginal, lap, or abdominal. Ovaries can be preserved, and the tubes can be removed at the time of hysterectomy. Uterus sparing resection is based on the principle that diseased tissue will be removed, normal tissue will be left behind. It will improve the clinical symptoms. You can do wedge resection or an adenomyomectomy. It relieves menorrhagia, alleviates dysmenorrhea, but there is a risk, as Dr. Asha Rao said, of a defective uterine wall and a risk of uterine rupture. There is also a risk that the borders are unclear and therefore diseased tissue may be left behind. And there is a risk of quick recurrence. So we do it when the patient wants to conceive quickly, then we can help them out and conceive. And when Grigoris did a beautiful systematic review of 64 studies and looked at complete excision, looked at cytoreductive surgery or incomplete removal, and even non-excisional techniques like endometrial ablation, and said that with complete excision, we are looking at 80% dysmenorrhea relief, 70% menorrhagia relief, and a good pregnancy rate. With partial excision, it's going to be a little bit less. But definitely there is a room for these conditions. Recurrence rates are worrying, and after excision with uterus sparing resection, there is a risk of recurrence. And recurrence, therefore, combined with the LNG IUS is more effective than doing just removal or IUS alone. And maybe in the future, we have a technique of intraoperative elastography, which may help us to identify all the diseased tissue and remove it and preserve all the healthy tissue. I think there was a little talk on uterine artery embolization and HIFU. These have also been tried. There are significant improvements in dysmenorrhea and menorrhagia. With uterine artery embolization, the impact on fertility is questionable. And there is a new QUESTA trial which is underway, which is the impact of uterine artery embolization on the quality of life compared to hysterectomy with symptomatic adenomyosis. HIFU is safe and effective, but no randomized trials yet, but maybe better for patients desiring fertility. And in select cases, we are not doing these things regularly, they may have a role. The new modalities of bromocriptine has also been studied. There's a danazol IUD, which is under trial. There are oxytocin antagonist receptors, which are in phase 1 trials, which may also be in the future. And as I conclude, I leave you with this road map. And I say, just to make things simpler, that if it's a 25-year-old unmarried patient, consider NSAIDs and tranexamic acid first and combined OC pills. If it's a 25-year-old woman who wants to do childbearing, best is to give GnRH analogs followed by IVF, or if surgery for localized adenomyoma followed by IVF. If it's a 35-year-old woman, family completed, consider LNG-IUS as the first option, or maybe a combined OC pill. If it's a 45-year-old woman, I think hysterectomy is perhaps the best answer, or the LNG-IUS if she doesn't want hysterectomy. And where combined OC pills are contraindicated, there is a role for Dynogest or aromatase inhibitors. And with that, I thank you all for a patient hearing.
Thank you, Dr. Sarita.
It was an excellent talk, Sarita, crystal clear. You
Yeah.
explained
Thank you, madam.
all the points beautifully.
And with the age-wise, you give a very clear-cut key messages, what is the best for that. Dr. Ashish is here to comment. Or otherwise, our last but the best, very important speaker who is remaining, Dr. Paul, PG Paul. So, Chairperson, Dr. Ashok is here, or Dr. Ashish will please introduce him. Hello.
Dr. Hafizur also is here.
Can I
Dr.
ask-
Hafizur Rahman, please welcome. Please introduce our next speaker, Dr. PG Paul.
Yes, ma'am. Good evening, ma'am, and good evening, everyone. So it is an honor to actually introduce Dr. PG Paul, sir. Everyone knows him, but still, that is, sir, is chairman of Paul's Hospital, Kochi, and he is board member of International Society of Gynecological Endoscopy in 2012 to 2016. Elected member of the Society of Reproductive Surgeons, ASRM, since 1997. He authored quite 2 books and contributed many chapters in books, published more than 50 papers, and there are innumerable invited lectures and workshops which you all used to see. And also, sir conducts hands-on training. So, and sir received Lifetime Endoscopy Empowerment Award. So, sir is going to talk an important actually talk, which is that is surgery for adenomyosis, when and how. And I'm sure it is going to be extremely important for all of us, as well as those who will be watching certificate. So I don't want to waste more time and invite Dr. PG Paul, sir, to start the presentation. The stage is yours.
There was some interruption in the internet at my place. So sorry for the delay. Can I share my
No,
screen?
sir, you are very much in time. You are very
Sure,
much
sir.
in time.
Okay.
Yes, sir. Please go ahead, sir.
Can you see my slides?
Yes, sir. Please go ahead.
Okay.
Perfect.
I have been asked to speak on the surgical part of adenomyosis. I know that you had an elaborate discussion on different aspects of adenomyosis. And who needs treatment for adenomyosis? We know that 1/3 of the people doesn't have any symptoms, and the next 2/3 are symptomatic, mostly heavy menstrual bleeding related symptoms. But recently, all our infertility specialists have found 20–25% of women do have adenomyosis, and it is affecting their results. So how do we select surgical treatment? All of us know surgical treatment is the last treatment offered for adenomyosis patients with symptoms. So when medical treatment fails, probably have no other option, then surgical treatment is required. And also in patients of infertility and recurrent miscarriage who does not respond to the standard treatment and still failure happens, then probably that's an indication for surgical treatment. We know that there are several challenges compared to myomectomy as far as adenomyomectomy is concerned. The first challenge is adenomyotic tissue, there is no surgical plane. So it's an artificial plane which the surgeon makes between a probably near normal to an abnormal tissue. And all of us know that you cannot enucleate and keep the myometrium. So always there is a loss of myometrial tissue and future childbearing can be compromised because of this. And all of us know that there is no standard technique of doing adenomyomectomy. Everyone improvises different techniques. And how do we choose at the moment is a difficult question. Mostly it depends on the extent of disease, also the surgeon's preference or experience. I just outlined the treatment for diffuse adenomyosis. Diffuse adenomyosis, we call it partial adenomyomectomy, and there are different techniques, but none of them appear to be very popular. The most popular one is Osada's triple fac technique. It's an open surgeon technique when you bisect the uterus and you keep a myometrium of 0.5 to 1 centimeter and then reconstruct and overlap with the 3 multiple flaps. My area of experience is on mostly focal adenomyosis, where we try to excise the complete adenomyoma. The classic technique has been described as a U-shaped suturing technique or overlap techniques. An overlap is always preferred because we know that the myometrium, there is loss and it will not heal us like a myomectomy wound, and probably an overlapping or support is required. I will show you a few of the videos with this in limited time. This is a 40-year-old woman with severe pain, and on scan we found a small cystic adenomyoma. This doesn't look like an ACUM which we normally see on the anterior wall and mostly connected to the round ligament. This patient did not want a hysterectomy. She wanted to conserve the uterus. Then I knew that is a cystic adenomyosis and an excision, which is comparatively straightforward. We don't have to worry about the myometrial repair because she has no plan to conceive again. But it's very important to make sure that you keep a flap of myometrium to reconstruct. Otherwise, the myometrium may not be, it will be very difficult to approximate. Those who have done in their early experience might have come across situations where they could not really approximate the myometrium after the adenomyometrium. So a complete excision and then repair is being done. This is comparatively straightforward, and the patient made an uneventful recovery and she was symptom-free. You can see a cystic adenomyotic cavity look like an ACUM, but we are worried why it did not have a symptom earlier. The next case is an anterior wall adenomyoma. She was 39-year-old, secondary infertility with she want to preserve, and you can see a large adenomyoma on the anterior wall. I normally don't use any uterine artery ligation. I normally prefer vasopressin, and I find comparatively compared to myoma, the adenomyoma bleeds less during the excision process. The main difficulty is how do you find your limit of excision? This is one of my earlier videos. So I made a T-shaped, inverted T-shaped incision and then tried to excise the adenomyoma in small pieces. I will show you in next video how you can little more plan this excision so that the excision can be as clear as much as possible. So here we are trying to feel and reach, and also we are injecting methyl blue to find out whether we are very close to. We always try to avoid opening the cavity in adenomyosis. So here we kept a flap, and we have not much difficulty in approximation, although it's little difficult. I did not do an overlapping, but try to approximate the dead space and then try to do it in 2 layers. These days, I was using purely the interrupted sutures with Vicryl, and the Bob sutures were not very popular at that point of time. Nowadays, I mostly use Bob suture, almost all suturing for the myometrium, whether it's myomectomy or adenomyomectomy. And the approximation is done with the good bites, and we are not doing any overlapping, thinking that a good approximation will heal well. Since she has severe dysmenorrhea, I also thought of adding presacral neurectomy. This patient has a lot of fat in the presacral area. So what we are trying to do is we're trying to dissect a triangular area and then excise the superior hypogastric plexus along with the fat. You can dissect the nerve itself. Now people are all experienced in identifying the hypogastric nerve, but in this case, along with the whole fat, I excised. The most dangerous part which can come over at this area is the division of the iliac vein. Sorry, this was another patient who came with heavy menstrual bleeding, and she had, you can see that a posterior wall adenomyoma, mostly distorting the cavity. So we decided to tackle this patient hysteroscopically rather than a laparoscopy because the adenomyoma was bulging inside. A technique which all you are familiar with doing hysteroscopic myomectomy for type 1 and 0 and 1 or even 2. And we use the resectoscope. Nowadays, all of us use smaller resectoscope than the original 26 French. Here, this is a 21 French. So we need less dilatation. And also it's very easy to visualize because when we use a 26 French loop, resectoscope, the loops are bigger and the pieces are bigger and it blocks all the view all the time, and you have to remove it frequently for a good visibility. Here, the technique is almost similar. We could completely almost resect the, and this is the end product, and the patient had a good recovery, and she also had symptom relief. The next case is again a nulli gravida patient who wants to conceive, and she had an adenomyoma and localized, injecting vasopressin. And nowadays I follow this 4-petal technique where you make actually a cruciate incision. So first you mark the 4 endpoints of your incision so that you can make a good planned excision. So all the 4 points are joined and a cruciate incision is being made. This allows you to have a good visibility and precisely excise the complete, almost complete adenomyomectomy. So you keep a flap of half to 1 centimeter. A harmonic comes handy. You can use any other instrument. Even scissors is good enough. And because the bleeding is comparatively less, I already mentioned that adenomyomectomy bleeding is comparatively less. We also measured on ultrasound how deep we have to go here, and this is almost 4 centimeter depth we made the incision. So that is one way of identifying the limit, and 4 big pieces of this adenomyoma is removed in complete. Another advantage of doing a hysteroscopy simultaneously, you transilluminate and see how far you are away from the your excision. Once you think that you have completed the adenomyoma excision, you can see a big cavity, but here we are planning to have an overlapping technique, a flat technique. So Bob suture comes quite handy in this case. You take bites on each flap, then come out so that there is no dead space as well as overlapping of the flap. You have to do a little bit of trial and error method to identify, to plan how you will overlap the flaps. And finally, the edges are, bites are taken on the edges to complete the suturing. You can use 1-0 or even 2-0 would have been better for this case. Here I am using 1-0 V-lock suture, and this is the end product. And she also had an uneven full postoperative period. Now the next major question is how the pregnancies do perform, do act. This was one adenomyomectomy I had performed earlier, and she had in 2020, and then 2023 she has come back, and you can find the uterus is almost looking near normal after the adenomyomectomy. So looking at the uterine rupture risk, there was a recent review article which looked at 2000 plus adenomyomectomies from 18 centers, and majority 13 centers were from Japan. As you know, Japan has the largest group of surgeons experienced in adenomyomectomy, and they had 449 pregnancies, and they had 13 uterine ruptures, and they also collected 11 case reports from the literature. So he compared how.
So sorry to interrupt, but your time is up.
Yes, 1 minute. Last.
Yes.
So the non-scarred uterus, it is very low. Previous cesarean is 0.2, myomectomy it is 0.2, but adenomyomectomy is almost 4%. And the major problem was majority of this risk of rupture happen antenatally, which we cannot really predict. So when we cannot have an overlapping flap, we use a mesh, a dual mesh, which people use for the hernia of the abdominal wall. We had published something of similar one where a mesh repair and the pregnancy outcome. I didn't have time to consider about the extrauterine adenomyomas. We had a few series, and I have written a review article in European Journal regarding extrauterine adenomyoma, a review of the literature. And to conclude my topic, uterine sparing surgeries, the techniques have almost improved, and in 70 to 90% patients do have improvement and pregnancy outcome. So when there is no other option, adenomyomectomy can be done, and maybe suggested. So thank you all for the patient hearing, and also I thank Dr. Asha Rao for giving me this opportunity to participate in this ICOG meeting.
Thank you, Dr. Paul. It was an excellent lecture, Dr. Asha Rao here. I have one question for you, Dr. Paul.
Yes.
What is the rate of recurrence and how soon does it recur in your experience? Rate of recurrence of symptoms.
Very difficult question, because majority of my cases were actually referred cases, and mostly my recurrence, I think, where I have done in my earlier series, the type of excision I was not doing, I was not really happy looking the present day technique. So probably it was how well you can do a good adenomyomectomy needs a lot of planning as well as good surgical techniques and experience.
And maybe you follow it up with the LNG IUS, right? After the...
especially those who have only symptoms, not the infertility and those who want to preserve the fertility.
Any comments, Dr. Hafizur?
Yeah, thank you, ma'am. Thank you so much, sir. I think it was quite informative, and especially there were case studies. Sir, I'd like to know, because in infertility patients, no, because when do you think that is to how much you need to stop? That means I want to be in, because you need to do, maybe you'll be doing background noise. So when you are doing, yes, sir, when you are doing surgery, because compared to those who are having pain, do you feel or you take special precautions in when doing for infertility patients?
Definitely, that's why I said your reconstruction should be perfect to bear the next pregnancy, because most of the pregnancy ruptures do happen antenatally, unlike the other myomectomies. So it's very important you reconstruct very well. If there is no overlapping technique, I suggest we should use a mesh reinforcement for such cases.
Such cases. Thank you, sir.
Yeah, I think
Yes,
we have had.
Yes. Can I make a comment, madam?
Sure, please. Yeah.
No, I just wanted to see all your up till now the session was very good. Everyone has presented and lot of information and knowledge has been shared on this platform. What I feel is it is not specifically for Dr. Paul, for everyone, especially Dr. Asha Rao can answer also. But see, HIFO, highly intensity focus ultrasound for adenomyosis. This is another option for the patients who are having pain or they are willing for fertility. In these patients, this can be used. Although this is not available in our country, but yes, in South Asian countries and now in Oxford and in other European countries also it is being available. So we never have a chance to discuss this modality of treatment. Any experience you have or anyone here?
HIFO is definitely an upcoming technique.
Yes.
It has been around for almost 15 years. But I think
no, the earlier, madam, there are two things in HIFO. Earlier it was MRI guided. Now the new technique which is there for last few years, I think 7 years or 8 years, is the ultrasound guided.
Ultrasound guided. I'm reading more
which
and more
is better
papers.
than MRI. They claim that
we
it
are
is
seeing
better than MRI.
We are seeing improvement in the results when I read in the
Yes.
paper, but we do not have practical experience. And they have even reported some patients getting pregnant after the HIFO, because initially it was used only for the gynec patients with the problems of menorrhagia, dysmenorrhea, and inability to operate.
So just to complete the thing, I added this topic that HIFO is
Even
another option.
intra-artery embolization can be tried for patients who do not want a baby but want relief from pain and menorrhagia, and who are willing to accept occasional chance of ovarian failure. So the non-invasive methods definitely have a role to play. So thank you all. We have had a wonderful session. I'm sure
Dr. Rao,
everybody has enjoyed. It has been a long day. Let us go in for the post-test questions, please.
I'll just like to make one comment here.
Yeah, quick. Nilima, you can put the link for the girls, for the delegates.
So whenever we speak about the GNR, so the link is in the chat box and you can all start, but I would just make a comment here that whenever we choose to use GnRH agonists, we must always be very careful in the younger age group, especially because it can have devastating effects on the bone and cardiac health. So obviously we cannot use it for a long time. And this is an important point. And I think HIFU is now available in some units in Mumbai. So, and I think I know somebody who has taken that treatment. So these are new things. Uterine artery embolization, again, Dr. Rao mentioned, there is 1% chance, 1 in 100, to have ovarian failure. And if that happens, then definitely an HRT should be taken, because till the age of 51, it is recommended to have reasonable estrogen levels in the body for the osteoprotection and cardioprotection. So we should not forget the general health when we treat for fertility. That's all I wanted to say.
Very good point, Anu. Thank you so much. And Neelima, shall we go in for the post-test questionnaires, please?
Yeah, it is on the chat box. It is on the chat box. The link is there. People have started, I think. So 8 minutes, 40 seconds are left.
Thank you so much, our chairpersons, Dr. Ashok Kumar, Ashish Mukhopadhyaya, Devika Gunashila, and Hafizur Rahman, for your wonderful moderation. You made the program so lively. Thank you all. And where are the answers? Yeah. We could have had so many questions answered during the 7 minutes, but I think we'll be disturbing the delegates by our talk. So let us wait.
Yeah, let's wait for that and then we'll do the official thank you because the time is already completed. Very nice. People have already started submitting. Good. चार्जिंग पे लगा रहने दीजिए। यहाँ से कहाँ गए? नहीं, इस पे मत लीजिए सब, इस पे खाली एंडोमेट्रियोसिस लेना है, तो अभी मत लीजिए।
Ma'am, time is up. Shall I share the answer sheet?
Yeah, please. We can do that. Okay. So let me start reading this. Question number 1. What is the estimated prevalence of endometriosis in infertile women? 50%. It could be 30 to 50% also. In endometriosis associated infertility, inflammation contributes to. Answer is disrupted follicular development. Scroll please. Infertility incidence among women with endometriosis is 30%. Endometriosis affects oocyte quality and embryo development by all mechanisms except. Can you just scroll it up because that. Yeah. The correct answer is immature oocytes. With regard to the use of GnRH agonists, the following statements are false. The correct answer is post-operative usage of GnRH agonists for 3 months. Good effect on pain-free period. Which of the following statement is false? The correct answer is in stage 1 to 2 endometriosis, IUI with COA should be done after 6 months of surgical treatment. You need not wait for 6 months. You can do it after a month or so. Following recommendations of ESHRE on controlled ovarian stimulation protocols for IVF in women with endometriosis is true. The answer is evidence on prolonged administration of progesterone as pre-treatment to IVF to increase the live birth rate is insufficient. This is the correct answer. This was a question by Jayaprakashan. 29-year-old patient is undergoing laparoscopic ovarian cystectomy for endometriosis. So what is the type of antibiotic will you give? The recommended one is IV cefalexin 1.5 gram with metronidazole 500 milligram at induction of anesthesia. So next is, what is the recommended approach regarding endometrioma removal before IVF? It should be considered on a case-by-case basis. This is the correct answer. So individualize. The best method of embryo transfer in endometriosis, GnRH downregulation followed by embryo transfer is the correct answer. So next is Mrs. X, 38 years, infertility, endometrioma 2.5 with mild pain, scheduled for ART. How to deal with the endometrioma? She does not require surgery, so we can do non-surgical management. No need for any of the laparoscopic procedures prior to ART in this 38-year-old woman.
Just a second, ma'am.
So Mrs. X, 38 years. Yeah, that's the same one. Small endometrioma, well-controlled pain, 38 years. So before ART, do not touch her endometrioma. Next is 20-year-old woman presents to early pregnancy assessment unit with abdominal pain, and ectopic pregnancy is seen on laparoscopy with left tubal unruptured ectopic pregnancy with normal right fallopian tube, and she has lots of adhesions of bowel on the right side due to previous appendicectomy. Uterus is bulky but normal. So how should you manage? Answer is, you do only left salpingectomy with adhesiolysis. Do not touch the adhesions because these post-appendicectomy adhesions are not bothering you for fertility. Regarding clinical recommendation rates, report on endometriosis, the true statement is the recurrence rate is 9 to 28%. Risk factors for recurrence include all of the above. So question number 15. So features of junctional zone adenomyosis are thickened junctional zone, irregular junctional zone, interrupted, all of the above. Myometrial cyst can be differentiated from a vessel by transvaginal sonography with Doppler. Consensus for diagnosis of adenomyosis is when the junctional zone is more than 12 millimeter. Globular uterus is a direct sign of adenomyosis, the correct answer. In fertility sparing surgeries, what is the optimum wall thickness one should aim for to allow conception and prevent further uterine rupture? 9 to 15 millimeter. This is the answer by Dr. Paul. Direct sign of adenomyosis is due to presence of ectopic endometrial glands in the myometrium. And the answer for the USC appearance of adenomyosis shown here in this picture is question mark sign. It's a beautiful question mark you can see. Effect of adenomyoma on infertility, all of the above. There is obstruction of tubal ostia, interference with embryo transport, interference with sperm migration, all of the above. What is the best method of embryo transfer in case of adenomyosis? Frozen embryo transfer after downregulation with GnRH agonist. Which of the following may affect embryo implantation in patients with adenomyosis? Decrease integrin B3. HOXA810 also is decreased. Regarding sperm transport, in uterus all are true except outer myometrium is a major contribution for peristaltic activity. That's wrong because, yeah. What is the main objective for surgical management for adenomyoma? To alleviate symptoms such as pain and abnormal bleeding. That's the correct answer. What is the potential complication associated with surgical removal of adenomyomas? Uterine rupture. That's what we are all worried about. Rate of uterine rupture following adenomyomectomy, I would say 6 to 8%. according to literature that have said it. Even Dr. Paul showed 24 cases for 2,300. I think it's not here. What are the surgical techniques of adenomyomectomy? All of the above. Wedge section, transverse H incision, Osada flap technique. All of the above is the correct answer. Regarding hysterectomy for endometriosis, the following is false. The correct answer is patient will have total relief of symptoms and no chance of recurrence. This is false because you can still have a recurrence in the even after hysterectomy. Yeah. I think we have had a wonderful day, and I would like Dr. Kiran Pandey to thank everyone that has supported us.
Thank you, Dr. Asha Rao, for giving a very good support and the guidance throughout this program. At the outset, I would say I'm very thankful to the opportunity given by our President, Dr. Jaideep Tang, Secretary General Dr. Madhuri Patel, ICOG Chair Dr. Paruri, and Dr. Sheila Mane, who's the Vice Chair, and was the series convener today. Dr. Asha Rao and the convener today, and Dr. Anu Chawla, they both helped me and guided me throughout the period, this program. And of course, I'm very thankful to all the chairpersons and especially Dr. Devika for taking all the responsibility through the first session, and the speakers, Dr. Anu Chawla again, Dr. Asha, Dr. Jaya Prakashan, Dr. Asha Bakshi, Dr. S. Krishna Kumar. They gave a wonderful, very innovative and very thoughtful lectures and very informative. And the next session we had were the chairpersons, Dr. Ashish Mukhopadhyay, Dr. Ashok Kumar, and Dr. Afizur Rahman. They conducted the program beautifully. Our speakers were Dr. Padam Shri, Dr. Asha Rao herself, Dr. Sarita, and Dr. P.G. Paul. They gave a very good, beautiful insight into the in-depth of the endometriosis, discussed very interactive sessions, the questions and the questions of the participants were discussed, answered, and many of the questions are being answered by the chairpersons. And I'm sure you must have learned, all the audience must have learned a lot. Let's see, the pre-test and post-test results will definitely tell us. But I'm sure as you were all focusing, so the results are going to be very good. And at the most important person I would like to thank is the Nilima, who has been working hard throughout these programs, and she technically she helped in all CVs and conducting the program. Thank you once again, all the participants. And if I've left a name, I'm sorry for it, but I think I've covered most of the persons. So
last but not the least, let me thank Kiran Pandey, ever smiling and energetic, for all the excellent work she has done the whole evening. Thank you, Kiran.
Thank you very much. So I think let's wind up the day today, and all the best to all the participants for the third day program, ICOG certificate course. And Dr. Asha, should we lead the program? I think everybody has submitted.
Yes. Yeah, everybody has submitted. Yeah.
So, okay.
So have a nice evening, all of you. And thank all the delegates for the excellent participation.
Yes, thank you.
Thank you, Kiran.
Thank you very much.
There's a problem with your audio. It's not very clear.
My audio?
Dr. Kiran's audio is very clear. So tomorrow, no, anyway, for today it's okay. I think
during the talk also it was less, is it?
Yeah. That's why I kept on putting it there that your audio is
no. Okay,
I
didn't
hear.
Maybe my laptop was a little far.
Yeah, maybe your laptop speaker is down.
Yeah, I should check. Thank you for telling me that.
Yeah.
Yeah, thank you. I always
thank
feel that my voice
thank
is
you very much.
Session. Thank you.
Thank you. So see you tomorrow, Bharti.
Good evening.
I'll be ready. Yeah, I'll be ready with everything.
Yeah, and I think Anu Chawla will be the convener.
Yeah.
So,
Okay, Dr. Bharti.
Thank you.